more than 75 speakers are from the international platform. And without much ado, I think we'll start this program, and I would request Dr. Gaurav Luthra to invite the first speaker.
Uh, a very good morning to everyone, and thanks, Namrata, for involving me in this session, the cataract session. We have our president joining in as well, Dr. Maipal sir, and
Yeah, good morning.
Maipal sir, would you like to say a few words to start off the session? I think you
Yeah,
would.
good morning, everyone, and welcome to this session, which is a combination of 12 international societies with All India Ophthalmological Society. It's indeed a pleasure to have all of you in this session. We started this webinar series on Friday, and it has been a resounding success, wherein we have the best of the talent from across the world presenting their innovations, surgical techniques, as also fundamentals of science to enrich the audience as to what is the latest that is happening. This particular session is about 3 hours plus 3.5 hours plus, which is going to look at cataract, which is one of the most commonly performed surgeries across the globe. And as you all know, that India today does more cataract surgeries than US, Europe, and maybe China put together. So we are indeed very grateful to the organizers, specifically all the societies and AIOS, Dr. Namrata, Dr. Rajesh, and the rest of the governing council. They have taken a lead part, and Amar Agarwal, and also I would say Gaurav, who has helped us in these programs to put this together. It is indeed going to be a good session where we have the best of the best, I would say, internationally, who will be presenting on various surgical techniques and the new things in cataract surgery. So without much ado, I will just also like to, yesterday also we shared the information. We'll wish to invite all the societies. In 2025, the APAO has been allotted to Delhi, India, and we would love to welcome you for that particular conference. So I have with me Dr. K.K. Mehta, Dr. Amar Agarwal. We have the moderators, that is Gaurav is there, Namrata is there, Dr. Himanshu would be there as convener, and we have several stalwarts who are with us. So without much ado, I think we will start with the session, and I pass on to Gaurav to take things forward. Thank you very much, Gaurav.
Thank you, sir. Namrata, do you want me to take the first talk as
Yeah,
planned?
I will want to take the first talk, Gaurav. It is a pleasure to invite Dr. Gaurav Luthra from Dehradun, India, to give his talk on avoiding chamber fluctuations with appropriate measures.
Thank you so much, Namrata. I'll just share my screen. So I thought I'll talk on something really basic for the benefit of the AIOS audience. And although we have stalwarts today, while being basic, I think it still is a very, very important aspect of cataract surgery, where whatever you might do, chamber stability probably is the key to a safe and successful, predictable cataract surgery. And whatever any number of measures that you might take may fall short. So you can keep improving the instrumentation, the technique, the machines. Everything is evolving in such a way that we are working at lower IOPs. We are working with better and better machines, which have which can sense the chamber fluctuations and make appropriate measures. But I'm going to talk more on small little tips which can help us beyond what we can do with the machines. So I think when we talk of chamber stability, we worked. I mean, I started doing phaco somewhere in '97 or '98, and that time Dr. Maipal sir was already, showing us how to do that. Dr. Dada, Dr. Maipal, they were the pioneers of phaco. Dr. Keki, and we were learning from them at that time. And we've come a long way. I remember my first machine was a Storz Protege, and it was a Venturi system. And we used to talk so much about Venturi and peristaltic pumps, and how one or the other might give you better hold or better cutting, better stability of the chamber. So we've come a long way. And then we had once I was somewhere around the 2000s, Dr. Amar came up with the concepts of, I remember he would tell us that, Gaurav, or anybody for that matter in live surgeries, put that bottle right up to the roof, and then we came up with a fish pump to increase the amount of fluid that was pushing into the chamber, so that we could have less surge and work with higher settings. So we've gone through the gamut of things, and now today we have these new machines which can actually work very well and sense the chamber stability. So the phaco-dynamics have come a long way with pressured infusions, with quick response fluidics on the latest machines. But then these machines can cost the earth, and every phaco surgeon, especially a beginner phaco surgeon, may not be able to invest into a very big machine like this if he's working on his own. If he's working, of course, in a big setup, he will be able to get all these things available to him as well. And it's always good to be able to operate on any kind of machine, and you should be comfortable working even on a basic machine and as well as on a top end machine. So what happens basically with chamber stability is that you can get surge, and if you're using especially higher settings for very hard cataracts, or if you're fond of using high vacuum settings and flow rates, you are more likely to get surge, especially towards the end for that last fragment. And what actually causes less chamber stability as well is fluid losses. So we are always looking for appropriate phaco tips and phaco sleeves, and appropriate incisions. So having the right size incision, having the correct blades, they make a lot of difference. And so we all look at the main port for having the correct you don't want a very tight wound because you'll get a wound burn. And if you have a loose main port, you will keep having fluid egressing and you will not have chamber stability from there. What very few people probably look at is the side port, and I wanted to talk about that as well today. And coming to, if we could minimize unaccounted fluid losses from the chamber, that would go a long way in improving beyond what we can do with the latest generation phaco machines. Of course, we all understand that when you don't have chamber stability, you can end up with so many things. You could have sudden inadvertent surge, and you can have a PCR, you can have zonular dehiscence, you can have with shallow chambers and trying to avoid going too deep, you can have endothelial damage. You could have iris prolapse from the side ports or main ports. You could end up having poor visual outcomes. You could have corneal edema, and of course there's a long list which is even longer than this. So I think the key is to have a controlled chamber and a controlled incision and a controlled infusion and controlled egress, and that's what is going to give you a good outcome. So here I wanted to show you a case where this was something which requires a lot of precision, and this is actually an old video, but I decided to show this because this is how I used to operate a few years back. Of course, this was a challenging situation, but I would want to ensure that this requires a very stable chamber. It's a very highly myopic eye with almost 16 cuts, RK cuts, and I prefer to do femto-assisted cataract surgery here because you can do many of the the except for the main incisions. I can have the nucleus already cleaved. I can have the rexes, so my number of entries and exits from the eye will be minimized because I'm only going in to just do my basic phaco maneuvers. And the lesser the maneuvers at the main port and the side port, the better it is, because as the surgery goes on and the number of times that you have to move your instruments around inside, the more the chances that your incisions are going to kind of reach one of the RK incisions and make them open up. So I prefer femto assisted, and many people think that getting the right rexis with RKIs is tough. But believe me, my preferred way of operating here is this. And of course, you have to be careful because you will get occasional tags, but you will very rarely get a broken rexis even with these RK incisions. And I've done, frankly, with many more incisions than this. Now, the importance here is that you should not have overlocking. So you should be ensuring that your incisions are controlled, and then the right kind of injector, the right instrumentation will make a lot of difference, because the lesser the handling of your incisions, the more the chances that you are likely to have a good stable chamber. What I wanted to share with you is here, if you notice that my side ports are how I used to make them 2-3 years back, is with an angled MVR, but we were making it with a 20 gauge MVR because that's what the Alcon machines initially used to come with, the bimanual IA. What I gradually realized was that, and this is my way of checking for any wound leaks at the end of surgery. I put a drop of trypan blue. You can see a stream of fluid coming out if you have a small leak, and micro leaks can be then sealed off, and that helps. And then I can just press the chamber to check if it's nicely sealed. How I evolved was, let's go on to the next one. And here another surgery where we innovated and we changed the kind of chopper. So I tried to match my incision to the instrumentation, of course, ensuring that the main port is of the exact size so that it's neither tight nor loose. So minimizing fluid losses from the main port during the surgery. And then I started looking at my side ports. So we started innovating with the choppers, and we started finding out if we can match the chopper to the incision size. And this, would allow me to have a better, I'm sorry, I would, it would allow me to kind of have a chopper which would match. But here again, if you notice, I'm purposely showing you this video. There is a lot of fluid egress from the side portal. Let me just take you back a little bit. Just watch. There is so much fluid coming out in this area. So even though I'm operating at with trying to have a stable chamber, now this continuous fluid flow is never going to allow me to have a stable chamber. And even though I'm trying to use a chopper which is wider, towards the base than at the tip, it is not matched to my size of the incision. So this effort is going waste. And as you make these maneuvers and stretch the wounds, the chances, or even depress the posterior lip, the chances of more fluid coming out even further increase. And you can have, especially if you're working at low IOPs as the new machines allow you to, even though they have pressured infusion, you will still end up getting occasional surge. And that last piece, you might just get, sudden PCR as well, or uncontrolled chambers. So to kind of preempt this and come around, I started then looking at, this is another thing which I wanted to show you. I hate these blades. I know that a lot of people use these even now, but just see, if you're using a blade like this for making your side port, you will never have a controlled incision. The incision size will never be controlled, because the longer you push it in, although it is shaped in a nice way, but you don't know what gauge incision you're going to get. If you put it too short, you'll have a tight wound. If you put it too far, you're going to have a very leaky wound. So there's no control on the size of your incision. Coming on, we decided to use, here we were innovating, and we started using 23 gauge MVRs for at the start of surgery, because we started innovating also with the bimanual handpieces, getting them made from epsilon and 21, 22, and 23 gauges, and ensuring that our incisions are matched. And now with the 23 gauge MVR, my chopper becomes perfectly matched to my incision. And now this, I can have a very controlled chamber. You can see that my IOP is, my bottle height is just 40 over here. And I can even operate at 35 centimeters bottle height at this time, which is equal to a pressure of just about 25, IOP of 25. So you can actually have a very, very controlled hard cataract surgery with almost no fluid losses happening, neither from the main port. So with the special sleeves which now come with these machines. And frankly, the whole purpose is that you don't need high-end machines for these small little maneuvers. All you need to do is match your instrumentation, your knives, and your choppers, and you can ensure that your wounds are not going to be leaky. Of course, now the challenge is that if you're using a 23 gauge bimanual IA, it is going to have problems with, you can see that the ports are really tight and I'm struggling to get my infusion in, and also maybe the other aspiration. But of course, that also ensures that my wounds are perfectly sealed and there's no fluid losses happening from my side ports as I do the maneuvers there. So it's a very, very controlled system. And even with very low IOPs, you can work very well with even high parameters as well. Coming on to my last quick video, and before we go on, I wanted to share that further innovation that we, I think I've missed one. Yeah, this is the last one. So here now we are making a side port. This is the one which I'm going to use later. So this is a 22 gauge, and my chopper, I'm going to make a 23 gauge to begin with. So once I make it with the 23 gauge MVR, angled MVR, and that's what I like, because you don't get surprises with angled MVRs as compared to other knives that you can use for the side port. So a very small side port, and this is matched to my chopper. And just watch how the chopper is not allowing any egress of fluid. So the chamber stability remains very good. And even if you're using a very basic machine, I travel for live surgery to several places, and you can get any kind of a machine anywhere. So if you are operating, you can kind of ensure that everything is in your control, not in the machine's control. And you can still have excellent chamber stability and minimize the surprises. Now, once the cataract is gone, I will enlarge my side port to a 22 gauge. So just watch, and then I'll finish my talk. Here now I'm going to have the chamber formed with side port infusion. You can see that it's going in a little tight, but that's what allows me. And now I'm enlarging the 23 to a 22. And now I'll be able to use a 22 gauge, which gives me perfect chamber stability. These are customized hand irrigation aspiration hand pieces with sandblasting. And these are very good on both things. Usually I'm sandblasted on my aspiration and infusion, very fine kind of sandblasting. And then you can go ahead and do an hydroimplantation. At all points, the chamber stability remains good. So the take-home message is that chamber stability is, I think, of utmost importance, as we all understand. and it improves the safety and predictability of the surgery. And of course, the perfect incisions make a lot of difference, and they can make or break a perfect surgery. So calibrating the side ports. In fact, Dr. Rohit Om Prakash has been innovating on this front as well. And I think, I don't know if he's talking today on this, but he has his own way of making these side port incisions which are non-leaky. And we've been working on the same front for a long time, but both probably give us similar results. So with that, I think I would like to stop here and thank you for this opportunity.
Thank you so much, Gaurav, for that excellent insight into small things that can make, chamber stable. I think we'll take one more talk and then we'll do the discussion. So I would now like to invite Dr. Steve Ashnoff from Canada to give his talk on immediately sequential bilateral cataract surgery. I think he's the best at that.
Thank you, Namrata. Let me just share my screen. Okay, so I'd like to talk to you about bilateral cataract surgery. First, I want to thank you for inviting me to take part in this excellent meeting. I've talked before in India about this, and the reason for choosing it now is I think that 2020 was a year in which very many people all over the world changed to bilateral cataract surgery, which makes me concerned because I was the first one in the world to do it routinely, and I've been encouraging everyone to do it. I really want to make sure people do it safely. So my question now is, are you ready? So these are my disclosures, none of which apply to this talk. So I have no relevant disclosures pertaining to bilateral surgery, and I've done about 25 webinars globally since the onset of the pandemic on this subject. It's interesting that I'm sure many of you know that cataract surgery was first done in India. Couching was done by Sushruta in 600 BC, and it took 2,200 years before we improved upon that, and extra caps or cataracts were done by Daviel. And then 1/10 that time, 200 years, until Ridley developed intraocular lenses, and then again 1/10 the time, 25 years until we got phaco. And then about 30 years later, we started doing bilateral cataract surgery routinely. 50 years after we began to do phaco, we started to do femto. And in the meantime, there was a group that kept doing what Daviel taught, and we're going along and doing manual small incision cataract surgery. And now all of these groups are coming to start doing bilateral surgery. And my view of this is that cataract surgery fixes an eye, but bilateral surgery, ISBCS, really restores vision because you fix both eyes at once and you get over a lot of problems that you get from doing one eye at a time. So I'm unaware of really any publication that shows bilateral surgery to be worse than unilateral surgery. Everyone I've seen shows that the complication rates in bilateral surgery are less, and they then say that it's not worse than unilateral surgery. So the reason that I perform bilateral surgery, in most of my cases, I think it's between 80 and 90%, is I think that it's better for the patient and really better for everybody else concerned. What COVID-19 has done is it really has encouraged everyone to do bilateral surgery, because we can now do 20 surgeries, let's say, on 10 patients instead of 18 surgeries on 18 patients. So we have fewer people around in the operating room and around the surgical center to pass around COVID-19. And we save time cleaning over the room and turning it over. And bilateral surgery has been shown to be safe and effective, so why not do it? But my point is that before you start doing bilateral surgery, really you have to make sure that every single step of your procedure has been perfected. I gave you a list here of things like dilating pupils, making sure you can manage small pupils well, different OVDs, what to use when, to understand your phaco machines, your settings, how to change them and what's better, to make sure your IAs are excellent and you don't break capsules. It was reported in the past that more capsules were broken doing IA than doing phaco. Your biometry has to be good and you can't have poor results. You have to have more or less every patient accurate. You have to use intracameral antibiotics, make sure your incisions seal, and you don't have post-operative complications, and you have to, of course, not use patches. And there are many more small things. And until you know that everything you do is right, you should not be taking on bilateral surgery. So I was the first in the world with Yining Strub and Ronit Yagev to make this publication in 2003 on my first little over 1,000 patients undergoing routine bilateral surgery, where the only reason for doing it is their preference. And the interesting thing in this paper was that we had extremely few complications, and that made me a bit concerned about publishing it because I thought I'd get a lot of noise. But what happened was that around the same time, over in Sweden, published in the same year, was an article by Bjorn Johansson in only 1/5 the number of patients, but nevertheless showing that they too were starting to do bilateral surgery routinely and weren't having a lot of problems either. At the same time, the Finns who were doing bilateral surgery but weren't publishing it began to talk to us, and the group in the Canary Islands of Spain did the same thing. And uniquely, as you see here on the left side, they did a study for the government of Spain, who eventually, a year later, approved that bilateral surgery was as safe and effective as unilateral surgery. So in all the various webinars I've done, the most interesting one was one I did in June with the University of Laval in Quebec City, because I found out that after I had spoken to them a few times, they took on bilateral surgery as routine for the entire department of over 20 surgeons. And they only did 6% of their cases in 2016. And by the time the pandemic started, they were doing 58% of their cases. And eventually they did really quite a few thousand cases, over 13,000 eyes. But they found that, like those of us doing a bilateral surgery study, that their infection rate was only 1 in 14,500. The only one to report an infection rate so low before that was us, the Bilateral Surgery Society, where we had a rate a little smaller, 1 in 15,000 or 15,500 in 100,000 eyes. But they were also using the moxifloxacin I recommended, 600 micrograms in 0.4 mils, and they were following the guidelines that I had given them. And so that was very good. And since then, I've had also discussions with the University of Alberta in Edmonton, who are doing the same thing and have the same results, and another group in Manitoba. All these three groups in Canada are similar in that they take care of a remote population, and that encouraged them to start doing bilateral surgery because patients came from far away for surgery. But they're all getting very good results, and so Canada is doing quite well in this. We weren't the first. I talked a few times about manual small incision cataract surgery, and the first to do bilateral surgery as manual small incision cataract surgery was Jacques Daviel, who in 1747 did extracapsular surgery and did them all as bilateral surgery. And he actually always did the left eye first, which gave me the idea of always doing the same eye first. And I also do the left eye first because that really minimizes the number of errors you might have if it's consistent in how you do it. The International Society of Bilateral Cataract Surgeons got started in 2008 as I began to find others in the world who were interested. We only had 9 members in the beginning, but we've actually accomplished quite a bit. I think the best thing we did is come out with our rule, which is that if any unresolved complication occurs with the first eye, the second eye should be deferred. But the thing we found out also is that the second eye is always easier. After you've done the first eye, you find out that the second eye is pretty much exactly the same. And every patient tells me that they went through the experience of the second eye easier as well. In 2009, we published this General Principles of Excellence for Bilateral Cataract Surgery. This has become now the global standard of how to do bilateral cataract surgery safely, and I recommend that you look at this. You can get it either on the ISBCS website or on the Eye Foundation of Canada website, where it's easily available. We used to have a lot of relative exclusions for bilateral surgery. You can see the long list over here, but as you get more practice, they decrease, and my exclusions now are extremely few. Borderline corneas that are bordering on failure, sepsis, and posterior polar cataracts. In the 25 years experience I have and over 12,000 eyes, I've only had 7 eyes where I had to defer the second eye, and I've only had to exchange the IOL for an error in the power before we had an IOL master. Since using IOL masters, that really hasn't occurred in anybody, that we've had an error of more than like 3/4 of a diopter. Also, in the past number of years, we've changed to do femto-phaco cases, and what I do now is I do femto-phaco, phaco. So we do both eyes femto, then both eyes phaco with 0 complications so far. I learned that from Laurent Lalonde, who was doing this in Boisbriand, Quebec in 2014. And I found that femtos are far better than regular phaco for very dense cataracts, white cataracts, moderate to severe pseudo exfoliation, fibrotic capsules, myotonic dystrophy, you have very, very elastic capsules, and posterior polar cataracts, where you can leave the last piece that covers the hole until the last thing that you do with this surgery. I think it's critical that we use moxifloxacin or other antibiotic in our surgery. I gave this talk at the ASCRS at the last live meeting we had, and it was well received. But the evidence has been very strong. In 2017, we already had 26 studies supporting the use of intracameral antibiotics with over 7 million eyes. And now since the study from India, from Haripriya Aravind and David Chang and Ravindran, adding 2 more million eyes in one study, It's overwhelmingly supportive of using antibiotics. I like to use dilute moxifloxacin because it allows you to expand the bag, center the lens with the extra volume, and also make sure that the amount you have in the eye is accurate, because there have been papers showing that it's much more accurate to use a more dilute solution. We just published this paper actually this month, because the question always comes up, is there any incremental effect of topical or oral antibiotics? So it turns out that the summary of this paper is that post-op topical moxifloxacin 6 times a day achieves an intracameral level, which you can see over here, just exceeding the mutant prevention concentration, or MPC, which is 10 times the MIC90 of the most common endophthalmitis pathogen, methicillin-sensitive Staph aureus. And this continues for as long as the drops are continued, but it is insufficient to kill the most resistant but rare POE pathogens, coagulative negative staph and MRSA, which are these 2 lines over here. You can see that only the intracameral gets a high enough level to kill off those 2 bacteria. So what does post-op topical drops do? Well, if you give it 6 times a day, it gives you enough in 4 days to give you the protection in case the patient rubs their eye and gets a transient wound leak. Whereas oral moxifloxacin, which some people give preoperatively by 12 hours and then again at surgery, only has an effect if the patient is septic at surgery, for example, if they were in a motor vehicle accident. Otherwise, it really has no benefit. I think it's advisable not to use patches. This is the regimen of post-op drops I use: moxifloxacin, prednisolone acetate, and ketorolac, and I give them a drop of pilocarpine at the end of surgery. I have them take the drop 6 times per day for 4 days, beginning 1 hour post-op, and the drops last this length of time you see over here. So in summary, the rationale behind doing bilateral surgery is it fixes the visual system in one shot, not just one peripheral receptor. It's better for the patient, it's better for the family, it's really better for everybody. And you can get the suggestions of how to do excellent surgery at our Eye Foundation of Canada website. It is rapidly increasing in doing bilateral cataract surgery all over the world, spurred on by COVID-19 and general acceptance. Follow the ISBCS general principles and be careful. Don't do bilateral surgery if you're uncertain of any of the steps of surgery. The reasons previously opposing bilateral surgery have not been verifiable. The risk of endophthalmitis is lowest in those reporting bilateral surgery. And if you need to adjust the IOL power in the second eye, it just hasn't happened. It's not a reality if you use Zeiss IOL Master or LensStar and topography. The real issue appears to be money, and COVID-19 is really a monetary incentive to be able to do more cases in less time, but to do them safely and to do what's best for the patient. Thank you very much.
Thanks, Steve, for that very nice lecture. And every time I listen to you, I get motivated starting to do surgery as well. So I think we'll have a quick discussion on the first 2 talks, as Namrata had said before, go the next one by Dr. Vasavada. And here I'll take this opportunity. I would first like to welcome some of our other speakers who have joined in during this time. So I can see Aiki there logging in from Canada. Welcome, Aiki. And I can see Ron. Welcome, Ron, for joining in. And I also see Dr. Dhami, who has joined in during this time. Welcome, sir, past president of IRSI. And I see Dr. Himanshu Mehta as well joining in, who's the current president of the IRSI. So I think we have a good team from IRSI, very good representation in this AIOS program as well. A quick talk, questions for a couple of people. So for the first talk which I had given, I would seek comments from Dr. Amar and Dr. Rohit, because they both kind of innovate in this on this front about how to get better chamber stability. Amar sir, can you take that first?
I think in 1999 we started the air pump. And since 1999 to now, we have always used in every case in Agarwal across the board, we are using the air pump. So it's a very simple, it's an aquarium air pump. At that time, I talked to Alcon in 1999. They didn't get my message at that time. Subsequently, in 2006, I talked to the BNL guys, and John Ukis was there, and he understood it. So they installed the air pump in the Stellaris machine. And we then did a study on with a thing. The advantage with those machines are you can monitor it. In the air pump, you got 50 and 100. In this, you can make it 30, 40, 50, whatever you want. Subsequently, then Alcon have installed it also in their machine with a simple system, which collapses it. But both work on the same system. It's just a better modification. The one problem with the Alcon's which you see now in the Centurion is they give both the facilities available. You can use the air pump system with the bottle on the top, or you can use the one which compresses. Some people were telling me in Minneapolis, if it's cold, or I don't know about Canada how it is, sometimes there can be some micro perforation because sometimes it can freeze. So in which case they shift to the bottle on this thing. But either way, both are simple. What our message is very simple. If you have a gas forced infusion, which was used a lot in retinal surgery and is used all the time in retinal surgery even today, I think in cataract surgery, the whole game changes. The word surge will never appear again in your dictionary.
Thanks, Dr. Amar. So, I wanted Dr. Rohit's comments because, I was speaking more on, going on from how we started with the high infusion pressures to how we can now work at very low pressures, also with minimizing chamber fluctuations. Dr. Rohit, you have been innovating on that front. Could you speak on your innovation?
I think it was a beautiful presentation by you, Dr. Gaurav, and it has vindicated, the concept that for chamber stability, you cannot give a stepmother treatment to your side port incision. You have the best machines in the world, but then if your side port is not calibrated by any means, then you can have turbulence around the side port incision with bellowing and touching of the iris at the side port with the side port instrument, which can create instability and lead to pupillary constriction and so many things. So side port calibration is a very important factor in delivering chamber stability. For the youngsters who do not have a high-end machine, chamber stability can be achieved to a larger extent by having incisions which are calibrated in the true sense. So calibrated side port incision has to be totally looked into deeply because it's a very small step which can make a large difference.
Thanks, Dr. Rohit. Quick last comment from Dr. Tityal, and then we go on to the next talk discussions. Tityal sir, any thoughts?
Nothing much to add because you have nicely presented the entire scenario. As Dr. Rohit was saying, it is very important to calibrate your incisions and match your incision with the instruments. If that is understood by the surgeons, they'll come out with all the difficult situations. So that is, I think, sometimes what happens, you have a different tip and different sleeve, and that can also mismatch the incisions. The incision has to be adequately matched by the instrument which you're going to use. If you take care of that, most of the time you'll come out with the difficult situations.
Gaurav, just want to say one thing. I want to comment on Steve Arshinow because he was a pioneer in this bilateral cataract surgery. And, Steve, just to tell you, see how far you have taken the game now to, where it has gone. And this corona has come into the time when I think so many people are doing this bilateral cataract surgery. I just wanted to compliment to you for your vision and forethought for that.
Absolutely.
Well, thank you. Actually, can I comment on Gaurav's talk?
Sure.
First, I have to confess that I saw a patient last week that was the first person on whom I ever did a phaco. When I started my training, I was ambidextrous and still am, and so they liked me doing surgery. And so in 1978, when I was really extremely new, no one wanted to do phacos, which are new things then. And so one of the mentors I had asked me if I'd do this phaco with him because I liked machinery and I was doing engineering before, and I was ambidextrous. So I did this guy, and I saw him, and he's still 20/25 without glasses. So I can tell you that from the very first phaco machines up until the current ones are much better. And with all of the new machines, you won't get surge from the machine. The time you get surge is when your incisions leak. Since from the very, very beginning, if you made tight incisions, you did not have any problems doing phaco. Most of the times I get videos brought by residents and others that are problems, it's because their incisions are leaking, which totally destroys any benefit of a very fancy phaco machine. The machine is irrelevant if the incision is not controlled because it's leaking so much. Now, Amar Agarwal's pump overcomes it by keep pumping in more fluid. But if you can't do that, or if you can, it's still just as good to make tight incisions because then you can lower the pressure in the eye. And you actually want to lower the pressure in the eye if you have things like low endothelial cell cramps, because that allows you to preserve the OVD in position for much longer. So you're better off to have tight incisions than to have a pump. You're perhaps better off to have both, but the first thing you have to do is make tight incisions so they don't leak.
Thanks.
So good talk, Gaurav. It was excellent.
Thanks a lot, Steve. And on your talk, I think, I needed to take comments from a couple of people. So I thought Rajesh would be the appropriate person here to chip in, because he works in a government institution, which is the top institution of India. And are you guys practicing? It sounds so convincing when Steve tells me this. I still haven't been able to get myself to do this full time. I occasionally do simultaneous bilateral. So Rajesh, any thoughts?
Yeah, Gaurav, actually, it's the same here as well. I mean, it's really sounds convincing, and we also don't get so many end-offs. And Tyal sir is here; he does huge number of cases every OT, but still, we have not been able to start bilateral simultaneous. So that hesitation is still there, and that
what holds you back? What holds you back?
Yeah, that feeling that probably in tropical countries the risk of infection is higher or things like that, and perhaps that's one of the reasons why we are a bit hesitant. But yes, still, I think I would also like to have Tyal's opinion, because he does so many cases, but still I don't think he has started simultaneous bilateral simultaneous. So that hesitation is there.
Yes, sir.
I think, especially what Steve was talking about, pandemic COVID-19 has given us a thought. It's not that for routine cataract, I don't consider doing a simultaneous surgery, but there are situations which we have shifted, like a phakic AIOS. We do a bilateral simultaneous surgeries nowadays for all patients, because getting a RT-PCR done for a patient within a few days is very, very tough. Similarly, pediatric patient, we all now shifted to bilateral surgery for all pediatric patients. And now, unfortunately, my OT are so heavy loaded, I can't think of doing a single person 2 eye that will extend my OT to double the time. So that is a consideration. Otherwise, I think it's a very good concept. Now we all understand infection rate is hardly there in a situation like ours also. So in future, if your number of cases are not that much, I'll definitely consider bilateral simultaneous surgery for these patients also.
For somebody who doesn't have access to optical biometry, is it still a good idea to think about doing? Because I would think majority of surgeons in India at least don't have access to optical biometry, and they could end up having refractive surprises, and many of them modulate their second eye based on the first eye outcomes. So that would probably be another consideration for us in India, at least to think about, for those of us who are listening in, whether they would like to do that. I would quickly take a comment here again from John, and then from Maipal, and then we move on to the next talk. John, are you doing simultaneous bilateral surgery? You have to unmute yourself.
Yes, I am. I've been doing it for quite a while. I do for monofocal lenses. I have no hesitation, and we have optical biometry. I do quite a lot of premium lenses, multifocal IOLs, especially torics. With those, I'm still doing one eye at a time. I think that even small changes, patients are much more demanding in that group. Another thing I do when I'm doing bilateral is I do tell the patient about the refractive surprise. That's one additional thing I say. Yeah, I think it's very important.
So Gaurav, I think, Gaurav.
Can I just one more comment?
Yeah, John.
One more comment about the your excellent talk. There is a setting in the Centurion, and I'm sure other machines. There's leakage compensation, which if you're having leaky wounds, you can kind of preset them. Unfortunately, during surgery, you cannot do that. And then there's you can switch, but you got to exit the thing. But another setting you have is the irrigation factor for tight wounds and leaky wounds. You can adjust that. These are two additional things you could actually help with the wound.
Absolutely. Great.
I just add, I think I would echo what Steve said earlier, that the control of incisions is far more important than relying on technology per se to get us out of trouble. So Steve, I'm in your camp, basics.
Actually, I was involved in designing the Centurion, and it can compensate somewhat for leaky wounds, but not if your wound leaks a lot. It's meant for small compensations, and if your wound leaks a lot, it's game over. All those fancy adjustments don't make any difference.
Yeah.
So, the idea is to learn to make tight incisions.
So I think, thanks, Steve. Coming back to the bilateral simultaneous, one of the things apart from fine-tuning the second eye result, I think the infection is something that obviously can be controlled, but still if you have that, The problem is that it's something is called a standard of care. So as of now, at least in India, the standard of care is to do unilateral surgery. And if something happens by chance, then you will be hauled up in the court, and they will take opinion that whether it's a standard of care or not. And you can have, with the rising incidence of consumer protection cases that are happening, you could go on to a medical negligence. So there has to be sufficient and more data, or even if AIOS or somebody, some society has to validate that this can be now considered as a standard of care. I think that is one of the other hesitancies that people in practice would have today, because as things stand, if you ask majority of the people, they are still on unilateral surgeries. Yes, LASIK possibly is the only exception where we are doing, and now, as Dr. Tityal was saying, we are moving on. So I think if that stumbling block goes away, that it can be put as a standard of care, that there is nothing wrong in doing that, then things could improve. But as long as it is not considered a standard of care, it can have repercussions as regards negligence cases.
Mahipal, with great respect, I can tell you that nothing that you do that is new is ever standard of care.
Agreed.
Anytime you change your phaco machine, anytime you change your incision, any little thing you do is not standard of care because it's new. So we would never advance by not doing new things. And I can tell you, I have been asked to go in front of panels of lawyers in Boston, California, Brazil, and about 10 more places to defend why I thought bilateral surgery was better. And in every time I got off, I've also been called as an expert in Australia, Canada, the United States, and various cases when someone was accused of a complication having occurred from bilateral surgery. In some of those cases, there was a complication, but it wasn't because of bilateral surgery. It was a complication in one eye because something else went wrong. So I don't think that the standard of care issue is an issue. And I understand that everyone says that, but I think when it comes down to actually doing it, it doesn't make a difference. I think what it comes down to is you being absolutely sure that every single step of your surgery is perfected. And once you're sure you can do it really well, you won't have any problems.
Yeah, I was just saying that that's cause of the hesitation, because as you are saying, you have been called up by several places to give evidence and things like that. So obviously there are patients who might have taken ophthalmologist or may have contested as to why bilateral surgery has been done. Because the simplest thing the patient goes ahead and says is that the doctor wants to make money, and therefore the doctor subjected me to something which is not standard of care, and he got both the eyes done. And I ended up in a complication in one eye, or God forbid if it happens in both eyes, then that's where you're to defend. So all that I'm trying to say, yes, there are going to be people who are going to be the pioneers, and you are a pioneer in this particular thing. And as more and more evidence comes in, more and more people will accept. And I think it is time that if we have strong enough evidence, which we have, then the societies or organizations should come forward and say that this is not something that should be not done. So the point is whether it can be done or it cannot be done. There are pioneers, and always for everything there will be pioneers, and I agree on that. But as things stand today, I think that is one of the reasons we have for a mind block, that God forbid if something goes wrong, something can happen. Like in my particular case, in a case of LASIK, a representative from Allergan came and he said that people wash the interface with that was way back, and they said that the people wash their interface with the lubricant solution rather than saline after the procedure, and that time they had introduced Celluvisc, and I just washed with Celluvisc, and basically it was very viscous. It stayed back, and the patient next day had bilateral DLKs, and the patient went on to have DLK eye wash, but there was a melt, and that guy was actually going in for a merchant navy selection. So obviously we couldn't get him to 6/6 vision. But then those are the things that need to be standardized, that one off, even if some case happens where you have a bilateral problem, you could be hauled up that why was this done, etc., etc. Sometimes, at least in Indian circumstances, I don't know, even abroad, you get infected solutions, a batch of this thing, infection, and people have been sent to jail. Like doctors have been sent to jail because of infected solutions. It happened very recently in South India. So those are stupid things that happen wherein you have to save your back That's the only problem, where even an industry problem, a solution problem, a toxic problem, anything that happens, and it happens bilaterally to a patient, that could. So it's not just infection, I think, but there are several other things that could go wrong, specifically because the quality of products still need to keep on improving. That's what's happening.
Thanks. So I think
Thank
we'll
you.
go on and
Yeah.
Namrata, please. Yeah.
We had a lot of discussion, and we have another talk on this by Dr. Ramamurthy, who doesn't believe that you should do bilateral surgery. But Steve, thank you so much. I think in the COVID times, it has really helped all of us when we've been doing bilateral surgeries. And I would now invite our next speaker, Dr. I.K. Ahmed from Canada. And he's going to be talking about very interesting topic, pupilloplasty, leave no doubt. And thank you so much for our friends from Canada for joining in so late in the night, both Steve and Ike. And Ike, over to your talk.
Thank you very much. I've enjoyed the discussion. It's great to see one of my mentors, Steve, advocating bilateral simultaneous surgery. I enjoyed writing a paper with Steve and Warren Hill recently, an editorial in ophthalmology. I thought it was a great review, and he's asked us to reconsider things. I wanted to mention one last point is we didn't hear about the patient perspective as far as, having the patient involved in discussion. I think if we involve the patient in discussions, often you'll find they lead to bilateral same-day surgery. It's a patient preference thing, and I think it's incumbent that we always take into account the patient's position as well. So I encourage us to continue to do this. Speaking of patients, it's my pleasure again to speak at the AIOS meeting, and of course with all my colleagues from India here and calling from Canada. It is a little bit past my bedtime. I don't know about you, Steve, but I'm sleeping earlier and earlier, but I got up in time to make this webinar. And it's a pleasure to speak here with such great colleagues with great skill and interest, and you've shared your work around the world. And of course, the pandemic has made it challenging to be with us in person, but always a pleasure to be here virtually. I'll speak about something that I'm very happy to see has become more and more the norm in discussions, and that is addressing pupil and iris abnormalities, an area that I believe has often been left and ignored for many years by many surgeons, but I see more and more interest in trying to address these for a variety of reasons. And I want to congratulate many folks here on the webinar here, including Amar, who's pushed forward, Namrata as well as far as pushing forward to really try to address techniques. And these patients, of course, complain not only of visual problems, but of severe functional issues and photophobia often. And perhaps most importantly, the cosmesis of the eye can really address or impact the patient's self-esteem and their self-consciousness. This was one of our local nurses a few years ago who had trauma to her left eye, and it just changed her life. Her self-image and her confidence had just dropped dramatically. And the ability to address this in a surgical fashion by recentering the pupil and addressing the abnormality, gave her an immense amount of self-confidence and really changed her back into being what she felt was more a complete, wholesome life. These cases require us to consider the tissue available to manipulate and suture and whether or not a prosthesis may be needed. We are thankful to have many prostheses. Some prostheses like these mortuary implants, whether they're in the bag or can be sutured to the sulcus, to the sclera, can be used. They, of course, don't address cosmesis, but they certainly can address issues that relate to photophobia and issues around increased aberration. The human optics implant has been a dramatically improvement in cosmetic prosthetic devices. Really can provide excellent cosmesis for patients, for example, like this patient with aniridia, who's had immediately postoperatively can see the excellent visual, functional, and cosmetic result. But we'll focus a bit on suture tying and addressing these defects with iris direct closure. And there are a variety of approaches that are important to grasp. And there are a variety of ways to tie sutures that are worthwhile to know. And I would say that there's no one technique that is the ideal technique for every eye. It's good to be familiar with the classical mechanical approach and all the other ones that have followed his initial work. This really allows us to have the versatility in the eye to address pupil and iris defects. There's some important instrumentation that are helpful to have, like have your trusty Sinskey hook and a Kuglen hook that can be useful. And then I think one thing that is very helpful and important to have is the right micro instrumentation, specifically micro graspers and micro forceps. Now, these have been designed particularly for the anterior segment, although one can use a variety of other type of modifications that have been designed, including vitreoretinal forceps as well. But I do like to use grasping forceps to manipulate the iris, and I do like to use tying forceps to manipulate the iris, to manipulate the suture, because these are ideally optimized for those approaches. And using micro tying forceps can be used, including the approach that one of my former fellows has called the McAhmed approach, which is really a very simple approach. It can be used, by the way, with any technique of throwing the sutures down, including the four-throw pupiloplasty that Amar has popularized as well. But this technique really just requires us to pass the suture through the eye in whatever approach we wish. This is, for example, a triple throw here, a triple bite through the iris, and then taking the ends out through a common incision. This can then be used with a micro tire to loop around the long end and grab the short end here, as we show outside the eye, and push the suture into the eye. If you're doing a fourth-throw pupiloplasty, add a fourth throw and simply push it into the eye. So this approach can be used really with any type of suture approach, but the idea is the suture tying can be done in a more elegant way, perhaps a more controlled way, using these micro tying forceps. And then, of course, we can also do, ultimately, what I love to do in many cases is to suture and tie the suture in the eye on its own. Let's just show some approaches here that can be described in describing these approaches. This is a patient who had an unfortunate interaction with phaco during IFIS, and the patient has significant prolapse of the iris, and you see the defect present here with significant photophobia that was present. In this case, you can see, although there is a fair amount of missing iris, it's quite useful to be able to manipulate the iris. The iris can actually be stretched fairly reasonable because of its elastic properties. And it's amazing that despite having almost a 3 clock hour defect, one can basically manipulate the iris quite well and bring it to close. I usually draw my line at around 3 clock hours. Once you get past 3 clock hours, it's a little bit harder to bring and manipulate the iris together. Here we're using this CIF4 tenoproline suture, and this is a suture of choice that we use to suture the iris. And having a curved needle is very helpful to approach this using 2 paracentesis incisions, which are, again, importantly placed here a few clock hours apart, 4 or 5 clock hours apart, to pass this needle here smoothly. And now we're just showing the McAhmed approach by tying the suture outside the eye and then pushing the knot into the eye here. And this allows the knot to be pushed back into the eye here and providing for direct closure. This is an easy, I believe, approach to learn to suture. And this allows the knot to be placed right onto the iris without the iris having to come out of the wound, which is one of the problems with various other approaches, including the classical mechanical. And then we can lock the knot in doing that, and that allows the knot to be secure. I do like to lock the knot, although, of course, I know that the fourth-throw pupiloplasty has been commonly used as well, and a micro scissor is used. And then we're going to continue to close this defect. We often use multiple passes to do this and close the defect. My advice is to take the extra time. This is not the time to do a very fast procedure and try to get done out of the OR right away. These require a bit of thought and planning and visualization and imagination, and the attention to detail, much like an artist would do as a painting, is important to really provide the ideal cosmetic benefit. Unlike other things we do in the eye, where how the eye looks inside may not be as relevant to the patient, at least in the world, although an ophthalmologist it might be relevant. In these cases, we need to basically, represent this patient's eye to the world. And it's relevant to make sure we take the time. Here we're making one extra throw here at the pupil margin to make sure that the pupil is nice and round. And this is perhaps an important aspect for our patients. Just as someone who does breast reconstruction would take the effort to ensure that the nipple is placed exactly well positioned. And I like to use this example because it's true. To our patients, the most important part of a proper pupil repair is centering the pupil properly and make it nice and round. To our patients, this is very relevant for the cosmetic appearance of the eye. You can see that in this case, we're using an intraocular tying approach using 2 microtires inside the eye that can be used. And at the end of the case, you can see we have a fairly reasonable cosmetic result. It's also helpful to use intracameral diathermy. And we use a 23 gauge endodiathermy needle that is, of course, used for hemostasis that can be helpful, which is rare. I must say bleeding is uncommon in these procedures. I get often asked, what about bleeding? It's very uncommon to get bleeding in these cases, except for the fact that sometimes with this traction placed at the iris root, it can sometimes be an issue. This is an example where not only are we trying to address the patient's enlarged pupil, we need to recenter the pupil as well. And so after placing the suture needle through the peripheral iris and closing the defect here using intracameral tying approaches here. By intracameral, of course, what I mean is we're basically tying suture in the eye for the most part using 2 micro tying forceps and very, very carefully observing the laws of physics, including ensuring that the instruments are used in the incision as fulcrum, using the incision as a fulcrum. Now, notice that we're using here the cautery device to recenter the pupil. This is a very handy approach to readjust the pupil size, especially to enlarge it in certain directions and stretch the pupil. This is much more desirable than cutting the iris with a vitreous cutter or scissors, where you lead to more irregular edges and loss of iris tissue. And you can see already the pupil is starting to position itself more centrally. Here again, we'll show the intracameral tying approach. Again, twirling our fingers in our hands, and truly the ultimate in ocular surgery is really ambidextrous bimanual approach. And I encourage all our colleagues to really work on that. In fact, I spent many months operating with my left hand after I broke my wrist as a fellow a few years, many years ago now, that I think solidified the importance of using your non-dominant hand, and really helps to do that. Again, we're closing that defect, and the pupil's looking pretty good, but I recommend not to stop here. Take the extra effort to get that final suture repair, your mark on this patient. And very much like we all take great pride in making a beautifully round centered capsulorhexis, take the time to make a beautifully round and centered pupil and make it round, and make it centered to really adequately do this. Now, the size is important. Obviously, we'd love to have a dynamic pupil, but that is impossible when we close the iris with sutures. We typically go to try to match the patient's fellow eye. You can see the pupil looks good, but you know what? Let's do a little bit extra intracameral cautery to get that linear edge a bit roundy, and you can see the improvement here. We typically try to aim for about a 3.5 millimeter pupil, which can help. Here's some more examples of pupil reconstructions here, as you can see. And finally, so the last case, not only an issue with an atonic pupil, but we have an iridodalysis here, and this can be repaired quite well. In fact, I think if Steve's still here, he'll remember one of our common patients here that had a very significant trauma to the eye and had a large iris defect. We can repair iris defects with taking the time to suture these adequately. Here, we're going to actually reposition the iris to the iris root here after do phaco emulsification and place an IOL in the bag. And we're placing an incision just behind the blue zone. The end of the blue zone matches up to the anterior trabecular meshwork. So if you go back about 0.5 millimeter from the blue zone, that'll put you just basically where the iris root will be. Go a millimeter to be sure, and avoid using the limbus. The limbus is not the best landmark for fixation of anything, including IOLs. Here we're placing a straight needle. I like using straight needles for dialysis repairs, and I like using multiple mattress sutures. I find this to be very controlled and very amenable here to bring the iris back. Remember, the arc length and circumference of the pupil, the iris periphery, is smaller than the circumference on the scleral side. So take farther bites from each other on a mattress suture on the scleral side than what you do on the iris. This will allow the iris to stretch and follow that angle adequately. So here we place multiple sutures. There's 3 mattress sutures on this side. I like to do slip knots, not to yet lock them, because we are still going to have to work on the iris. And one of the mistakes I see commonly surgeons make is that they repair the iridodalysis, but they forget to repair. In this case, we have an atonic large pupil as well, and so we have to repair this pupil as well. One of my favorite techniques is using an iris cerclage technique, pupil cerclage technique, using, again, back to the curved CIF4 needle. Here we're using our left hand with the needle, and we're using our right hand with the forceps, and really it's the forceps that does the work here. The forceps brings the iris to the needle in a circular fashion or baseball stitch fashion to allow for a nice round contour, and that really provides a nice appearing pupil. We'll do this in 4 quadrants. coming out of the eye through the incision, of course, to make sure that we can go back in the eye, make sure not to trap the needle in the cornea. And we go back around the double arm suture here. Again, being careful here in the area of the dialysis, of course. We have a complete round circle. We're going to now tie the pupil here with again, a McOmid approach, looping outside the eye and drawing it inside there with a micro tire. And we now have a pupil size that is reasonable. We're going to go for about 3.5, and then we can lock these sutures outside the eye. It's okay to hang it back a little bit from the periphery. And we've now reconstructed this patient here in a reasonable way. This is post-op day 1, and really it's hard to tell the pupil was damaged at all. I haven't been able to speak a lot about a variety of other approaches, but I hope that was somewhat helpful to share with you some pupil and iris approaches. Thank you very much.
Thank you, Ike. I think that was a very phenomenal set of videos that you showed on iris repair. And I would ask Dr. Rajesh Sinha to comment. I know he also deals with a lot of such cases. Rajesh, would you want to give your comments?
Yeah, I mean, these videos were phenomenal, and the way the last video was absolutely fantastic. It was a treat to watch. These days, however, I'm preferring more of the Dr. Amar's technique of single pass 4-throw pupilloplasty, and what Ike was mentioning that, you know, in some of the cases, you know, we get a 3 millimeter pupil, but still we don't get that round pupil. So in that case, just a small bite at the edge of the pupil really works and gives a lot of satisfaction. So I also feel like doing that. And single pass 4-throw pupilloplasty, what I felt was a very simple technique and very easy to use. So I'm doing it very frequently. And a few of the pinhole pupilloplasties also I have done, and it works quite well.
Anybody else? Amar, would you want to comment on?
I think I want to comment on Ike's surgery because such an excellent surgeon, and important is Slack's new book is coming out.
Amar, we've lost your audio. Yeah, Amar, we've lost your audio.
Amar, we can't hear you.
We can't hear you, Dr.
We
Amar.
can't hear you, Dr. I think he can't hear us.
Yeah, okay. Yeah, we can hear
You
you
will
now.
have to repeat that again. We couldn't hear you.
I said that Michael Snyder's hangback technique of iodialysis, which Ike showed, was very good. We have modified it to the trocar-assisted iodialysis because it makes a huge difference, because many times the needle gets stuck onto the corneal incisions, you know, and plus the needle moves a bit. With the trocar, both these problems are solved.
So, Namrata, I'll just wish to make a small comment. There is a small innovation that we have described. It came out in the Indian Journal of Ophthalmology, the last issue. And that is because most of these techniques, like Ike showed and what Amar has shown, is that they're looking at pseudophakic or aphakic eyes. Now, in case you have a problem in the iris and you have an irregular pupil and the patient is phakic, how do you handle that? For that, what we have said is that you can go ahead and put like a phakic implant as a scaffold. So you go in, put a phakic implant below the iris on top of the crystalline lens, and then you have a scaffold. So then you do whatever you want to do as regards the pupilloplasty, whatever you want to. And before tying the knot, you just take out the implant and then tie the knot. So the issue of a needle hitting into the normal crystalline lens can be sorted out by having a scaffold. So that's just been published in the Indian Journal of Ophthalmology as a surgical technique. And we have done that in 3 cases so far. And that is a way where you don't necessarily need to make the patient pseudophakic in case you have an iris defect and you want to repair it.
I think.
Yeah, I think that's a clever approach, Mahapal. I would say that I wouldn't be shy in doing phakic iris repairs. We have, I think, a series of 40 or 50 cases, but I think it's very clever using a sulcus-based temporary ICL. It's an interesting idea.
Yeah. Maybe you can try it to validate it for me.
That sounds great.
Comment on, yeah.
Well, I just want to comment to thank Ike for a great talk. It's nice that he acknowledged with one of his mentors. And, you know, it's very great to be a mentor, to have a fantastic student like Ike, because I now send him those patients to do. And he's done a great job in all of them. So that was fantastic, Ike.
I think it was.
Well, most of you know that Steve Arsenault is the reason why I'm an ophthalmologist. So I'm grateful to be here.
So I make use of him.
So Mohan wants to make a comment on it.
Ike is really fantastic, incredible stuff, Ike. I just want, because I was surprised that you didn't mention about the SFT of Amar's technique. And because as an extension of SFT is a pinhole pupil plastic, which you are also doing now. I find putting the knot inside, that is intracamerally, is more difficult for us. But when you take the loop outside and put the fourth through, it makes the life easier for us. And you can just put that's what I do. We do all, because we do the Amar's technique SFT. So because putting the knot inside, sometimes it's very, very difficult to put the knot inside. In your hands, it works very well. But in our hands, I think taking the loop outside and putting the fourth row makes it a little easier for us.
Oh yeah, no, I completely agree, and that's what I was saying. That whether you do a 4-throw, or 3-throw, or 2-throw, doesn't matter. The point is that if you use a micro tire to push the knot into the eye after you throw it, it's very easy. So you can do the 4-throw using a micro tire to push it into the eye. So actually, the way the throw is made is what the difference is. Whether you do a 1, 2, 3, 4, 5, 6 throw, it doesn't matter. The key is tie it outside the eye, like you're doing, and then push it into the eye. This is a very easy approach, whatever approach you use. And it's up to you whether you want to do a 4 or 3 or 2 or lock or not. That's really more of a question of whether you want to lock it or not. The real innovation is, of course, how do you handle the sutures and where do you bring them out and everything else.
Yeah. Thank you. Thank you.
Thank you so much, Ike. Thank you for that wonderful talk. And it is my pleasure now to invite the next speaker, none other than Dr. Abhay Vasavada, stalwart from the Indian side, who's going to be talking on a very important topic, and that is management of posterior polar cataract.
Thank you, Dr. Namrata and AIOS for giving me this opportunity. I do receive research grant support from Alcon from time to time, but has no relevance on these presentation on the management of posterior polar cataract. And I do recognize the contribution of many stalwarts, including Dr. Osher and the colleagues who are at the moment present in the webinar, from whom I've learned a lot. So I think it's over the years that the principles have evolved, and we understand much better now how to remove that posterior polar cataract. And the first pearl I would think is to avoid any rapid buildup of hydraulic pressure in the bag, and therefore the subcapsular or a corticocleaving hydrodissection should not be performed like in a normal cataract. Also, it's important to create a mechanical cushion effect when you remove the nucleus and when you do all the gymnastics. So that will protect the thin central area. And the conventional way of hydrodelineation does the trick most of the time, but sometimes it can lead to inadvertent subcapsular fluid wave, which can produce a hydrorupture. So we devised a technique and published it in 2004, what we call inside out. The delineation is performed from within the core of the nucleus, and you can titrate the level of the injection that you want to do. You can have a thinner epinucleus or thicker, depending upon the level of penetration you make, and also a chance of inadvertent hydro rupture are reduced. And this video illustrates that with the band cannula, you can decide what level, anterior posterior level, you want to penetrate and generate demarcated central nucleus. And you can repeat this on the other side if it doesn't work. But creating a cushion is, I believe, is important. We also need to understand that we never want to avoid, we want to avoid the forward bulge of that posterior capsule and zonules, and therefore adhering to the closed chamber technique principles of that are very important. And as you would see here, inject, and I inject this coach here, but whatever, before you retract the instrument out, will obviously reduce that forward bulge, and that can be applied any procedure, any time. And if I'm doing bimanual, and I would recommend bimanual here because the main valvular incision is not compromised, you need to inject again OVD this coat before you swap the instruments and make sure. So I think avoiding bulge. The fourth I would think is to create a communication between anterior and posterior compartment of the capsular bag. In other words, it's not coming up, but I will show you in later on the film that when you remove the epinucleus, you create a communication between the posterior compartment and the anterior compartment, so the fluid pressure doesn't build up. The hydraulic pressure is very minimal, and I believe using flex surgery is very important, and our colleagues all across the globe, and particularly Dr. Jivan Tithyal, Namrata Sharma, Mahipal, and all have shown their own ways of doing it. And we published a paper on that on 2015, how a delineation has reduced our rupture rate, which we reported earlier in 90s of 34%. So whatever the techniques, but I believe that the flex technique helps us, and Dr. Samresh Srivastava has shown us in his animation how that different layers protect. When you remove one inner layer, the outer layer keeps protecting the weak, fragile capsule, and then you need to address that separately. So this is a video showing the delineated produced by the flex, and I use the Lensec, but all machines can have that, I believe. And then you remove with the appropriate flow rate. You don't need very high bottle height. You don't need very high flow rate, but appropriate energy, a little more energy than the vacuum, and you can shell out those rings and demarcated nuclear material and present it to that. And that's what I mean by establishing a communication between posterior and anterior compartment. You do not detach it completely, and then the fluid is balanced between the two compartments, and then you can produce a subcapsular hydrodissection also in the subincisional area to remove that epinucleus if you wish. So that's what is happening. You can use the bimanual approach or subcapsular hydrodissection to bring it to the center, but because of the closed chamber technique, bimanual has an advantage, and that communication between the two compartments avoided that. And the best part of this flex technique is it works for different grades of nuclear cataract. The inside-out manual delineation is not easy to perform if the cataract density is quite dense in the nuclear part. So this one has an advantage that you can achieve that in a dense cataract as well. And as I said earlier, our PCR rate has dropped down in 2015 or 16 to 3.8 from a very high incidence that we reported many, many years ago. So I recognize the contribution of Dr. Namrata Sharma, Jivan Tithyal, and Manpreet Kaur on these subjects, and there are quite a few others which will allow us to refine and make this extraction very safe. But the last and very important, I believe, is to explain what disease the patient have, what are the complications that we may have preoperatively, and mention about the drop nucleus or multiple intervention, and we may have to change our IOL fixation if it is planned in a particular way. And typically it would be a toric multifocal plan as in this posterior polar with a small pupil. So remember, the posterior polar cataract is not over until it's really over. So we are very happy to remove this posterior polar cataract, and then this is what happens at the end. So Dr. Centurion from Brazil has reported such a scenario, and this is, I believe, we also found the same. So posterior polar, until it is real, the speculum is out, please be attentive. Don't ask the assistant to pack up the moment the lens goes in. And this is the same patient post-operatively. So I think these are the basic fundamentals. As I said earlier, I have learned from many other colleagues over the years. I take two cases to illustrate: a unilateral posterior polar cataract with suspected posterior polar defect, and the Lensec flex will help us to anticipate that with their imaging technology. So here is the idea is to reduce the chance of vitreous prolapse through that defect, and to make sure that the defect is not enlarged. And this is therefore we are going with a modest IOP and taking our time with a low parameters and adhering to all the pearls that we discussed. And this is the time which will happen whatever you've done with the nucleus. And therefore, you will see that we are taking even more time. And that's here, once again, keeping this main incision secure by not passing a IA probe helps me to maintain the contour and closed chamber technique. And this is what it is now. So first thing is to not panic and inject this coat, and then perform vitrectomy. But before you do that, identify and using preservative-free triamcinolone, and I use Orocort, which is very safe and very good. And then performing pars plana vitrectomy will allow me to reduce the chance of extension of that posterior capsule tear, and then will let me handle that tear appropriately. Once that is done, doing bimanual cortex removal is not a difficult thing. And then we need to see how to make this tear stronger. And then using the principles of posterior capsular axis, converting those two ends and rounding off will strengthen that tear. And if you can enlarge that and give even a better shape, it's good, but at least round off the two ends of the tear so that it doesn't extend when you implant. And then we continue with our original plan of toric IOL. And as I said, this would be either multifocal or toric when there is the posterior polar. That's a rule and the exception. So we could do that with all that care and converting that tear into the stronger margin, and always check it at the end, the presence of vitreous, and make sure that your incisions are good. And this is how it looked day one and later on down the post-operative time. So I think you can address if you take time, and I believe that Flex does help in managing that and take care of the pars plana vitrectomy or any anti-vitrectomy you think, but I feel pars plana is good. This is a traumatic posterior capsule rupture in a posterior polar cataract already. And once again, this technology allows us to identify and adhering to the same principles of the delineation and going very slow, helps us to reduce the prolapse of the vitreous. And this being a very fibrotic margin of the tear, we were already very lucky, and we didn't have to do vitrectomy here once implant, but we could continue with our original plan, making sure at the end that there is no vitreous in the anterior chamber, and keep the irrigation in until you hydrate the incision. And this is how it looked down the line. Always remember to refer it to the posterior segment surgeons for macula and peripheral retinal break event in the same day, next day as early as you can, and keep them under follow-up. So thank you so very much for your patient hearing.
Thank you so much, Dr. Vasavada sir, for again that excellent insight into posterior polar cataracts, which we've been listening from you for last so many years. You've done tremendous amount of work. I would request Professor J.S. Tityal, who's also been doing a lot of work and described a new sign very recently for posterior polar cataract, to please give his comments.
Yeah, first of all, Abhay, it was a wonderful presentation as usual, giving a entire gamut of posterior polar features and managing these cases in such a nice way. And thank you for taking your publication in your presentation also. Recently, it's come up in a JCRS now, that sign we all have been seeing, but nobody had clearly described. We described that intraoperative posterior polar cortical disc defect sign. So once you see this sign towards the end of your emulsification or towards the end of your epicortical aspiration, the disc which is visible, that's a clear sign for intact posterior capsule. And we found that in almost 84% of our cases, we could find the disc, and surgery was very uneventful in those cases. In the rest of the cases where disc was not seen, those cases either we had a total defect in the posterior pole, or there was an adhesion which was so strong it never let the epicortex to come off. And these cases had almost 10% chances of a posterior capsular adhesions happening towards the end of surgery. So disc defect sign is a very good sign. People should not get worried that your posterior capsule will get damaged at this stage. That's a clear sign that you have a safe surgery in a posterior polar cataract.
I think
just come out with the JCRS.
I think this is Jivan. This is a very great reporting, and we all, as you said, know that. But I would caution to posterior cap vac these patients. Even if you see the disc, try not to clean the posterior capsule with vacuum cleaning, whatever low parameters is, because you can get surprises even in the eyes which have the disc. So it's very nice to see the disc, but please refrain.
I think we are losing audio.
That's a absolutely correct way to approach, because these cases can have a rupture of posterior capsule at any stage, which Abhay showed to us a hydration type time also. I have had multiple cases where after implantation IOL, during viscoelastic removal from behind the IOL, I had an opening of the capsule. These things can happen, so we have to be very, very careful till the patient comes out from the table.
Namrata, can I make a comment?
Yeah.
No, I think the flax is, in my opinion, the game changer as far as posterior polar cataract is concerned. And after seeing Mayapal's paper, I'm fully convinced about it. I'm doing, even if the patient cannot afford, I do flax because my intraoperative control is much better with the flax. So that is the take-home message. If you have access to flax, even if the patient cannot pay, I think it's worth doing the posterior polar cataract flax, because you can end up with less complications. Even if you have complications, you are in a better position to control them much better.
So I think,
Mohan, you are absolutely correct. Femtosecond does give an advantage, as Dr. Abhay showed the safety rings of delineation with the flex. We have described the hybrid technique for a nucleus, which is a little harder. So in place of just 3 safety ring, we also do a chop also, and that makes the nuclear chop with the multiple blocks. You can take block by block and leave the cushion till the end safely. And you're right, it does help. Dr. Mahipal rightly described the sign you can pick up with the OCT picturization also.
So I think Dr. Tityal and Mohan, thank you for acknowledging that. The important thing is that people should not, there is absolutely no confusion that femto laser takes the safety margin much, much higher. And as Abhay has also said, I have not had any nucleus drop in any of the femto cases where you have, because you are able to delineate the safety margin. I don't do the concentric rings at all. I normally do the chopping, but the margin is given as a safety. And you are able to take out the entire nucleus with the epinucleus still remaining as a cushion. And you really don't need to do any hydro procedure, because the pneumodissection is in itself very sufficient. Just now, the thing that I want to emphasize is that a pre-operative clinical examination with the OPD tools can also give you a good indication as to if there is a pre-existing rent in the capsule or not, especially in immature cataracts. And that would include an IOL Master 700. If you look at the image there, you can look at the capsule that is there. You can look at an anterior segment OCT, and even you can get on a pentacam. So these are the images and the slit lamp examination. These are a couple of the things that all of us can do, even if you are not having an access to a femtolaser procedure a machine, because the integrated OCT at that particular time gives you a fantastic image. But these OPD things can also give you a good enough image. The procedural efficiency increases with the presence of a femtolaser, but the diagnostic part has to start in the OPD itself, where you can see. So now I am 100% sure when I'm seeing a femtolaser image, when I'm doing a femto procedure on a posterior polar cataract, whether this patient will have a posterior pre-existing defect or not. And that is giving me 100% of specificity that this, and I have not failed in a single case where I have said that there is a defect or there isn't a defect, which you can see on the OCT image. So importance of imagery is very, very critical in the posterior polar cataracts.
Can I, Mayapal, I think you brought out a very, very important point, and it's very fundamental that we see it. And I want to recognize late Dr. Daljit Singh here, because he was the first one, to my knowledge, who described these dots in the anterior face or behind the capsule, which we labeled it later on as the fishtail sign. So I think the good clinical observation still stands very good, and Maipal brought that up very well. Thank you.
And also look at the fellow eye. It's very important, posterior polar cataract. The fellow eye has got an iris claw lens or an AC IOL or a lens in the sulcus or even aphakia or a glued IOL. You have to have a high index of suspicion. This patient probably has a posterior polar cataract in this eye.
I think Dr. G.S. Dhami has also done a lot of work on the preoperative diagnosis, ASOCT especially, for these posterior polar cataracts and for white cataracts both. So we recognize.
You're muted, Dr. Dhami, unmute.
Muted.
Thank you for putting me in. I think sync sign, what is Dr. Zavda has mentioned, is a very good sign. And especially now with the IL Master 700 coming up, there's no risk that you cannot assess it preoperatively. Of course, missing it on a normal slit lamp examination is not possible. So clinically evaluating every cataract, whether it is a polar cataract or a white cataract or even a dense cataract, you can really save yourself from a complication. It was sync sign which really taught us when we used to do ECC and RS claw lenses to save our posterior polar cataracts and reach this stage, getting it to IL Master 700, recognizing it preoperatively. Thank you.
Thank you so much, sir. I think now we'll go on to the next talk. And the next talk is going to be by none other than Dr. Amar Agarwal, who's always taught us how to deal with nightmares and various surgeries. And now he's going to be telling us about challenging cases. Over to Amar.
Thank you, Namrata. Let me now just share my screen with you people so that you let me know. Is it coming?
Yeah. Yeah.
Okay. So I thought I'll just show this first case. This case came to me from Poland. He is an actor there, one of the top actors in Poland, and he had this problem where there was a corneal damage, obviously, as you can see there. Plus, look at the iridodialysis. It's a huge amount of iridodialysis, and it had come right to the center. He has an IOL also inside the eye, as you can see. So I'm taking off this epithelium to see better. Now you'll see slightly much better. And you can see, first tip is I need fluid in the eye. So I'm fixing my trocar AC maintainer there. Now I've got fluid going inside the eye. Remember the simple trick. There is a capsule present. So I don't need to go from the back. Rather than fixing an infusion cannula in the back, because there is a capsule already, or fixing an AC maintainer, the trocar AC maintainer goes through the sclera, 0.5 millimeter from limbus, and it is snugly, tightly fixed. Now, wherever the iridodialysis is, and you can see the iridodialysis there, right opposite it, I'm fixing my second trocar. So you can see again, this trocar, you can go through sclera, go through cornea, whichever one you are comfortable in. Once you have done that, look at the next step, which I'm going to do. I'm making my side port incisions. I've also created a groove, if you notice, in the sclera, in the area of the dialysis. Now I'm taking a double-armed Prolene needle. So this is the double-arm Prolene needle. This is the hangback technique, but we have taken it to the next step by modifying it using the trocar-assisted iridodialysis repair. Now you notice that Prolene needle has gone through the iris. From the other side, 30-gauge needle going through the scleral groove. Now I connect the two. Once I have connected the two, you will see the needle coming out through the scleral groove. Railroad technique, pulled it out. So far, so good. Now remember, this is a double-armed Prolene needle. See, the advantage of the trocar, understand, is I am right opposite the area where I'm operating. It's very tough to pass that through a clear corneal incision. The trocar helps me. Second thing is, when I pass the trocar and the needle through the trocar, you see my needle does not move and rotate. Otherwise, I tell you what, it rotates so much, it's very difficult to catch the iris onto it. Now watch, I've passed the second arm, I'm holding on to this, and now I will pass my needle into the iris. Now this is the second arm. Again, you can see from the other side, I've taken the 30-gauge needle and I'm going to bring it out. So this is the trocar-assisted iridodialysis repair. Now, once you've got both the arms out, as you will see just now, all I have to do is pull. And when I pull, and you can see, I'm just going to pull it out, and you can see there it's pulled. And now all I do is suture it, and that goes into the groove. Now you can do this as many times as you want. So look, I'm just rotating that, tilting it a bit, the trocar, and the same trocar is being used for my remaining portion of the iododialysis, because it's like a fulcrum, it just moves. So here you can see now another portion of the iododialysis being repaired. We have published this also in the European Journal of Ophthalmology, in the EGO. It's already been published there. Now, once I have done that, the problem now what happens is, remember, when I pull the iris and pull the iododialysis to one side, the pupil gets large. So to solve this problem, we have this technique, which is the fourth row pupillasty. And using this technique of the fourth row pupillasty, you'll see me, first of all, I'm going to break these synechiae which are present there, because this produces glaucoma if there is a lot of anterior synechiae there. Once I have cracked these anterior synechiae, my next step is I want to make the pupil smaller, because the iododialysis repair has happened, but still my pupil, because of that repair, has become distorted. So now I'm doing the single pass fourth row pupillasty. I pass the needle through the clear cornea, and once it's there, you see I'm going to through that area. From the other side, I'm going to use a 30 gauge needle. Remember one thing, you don't need a paracentesis on both sides. You just need it on one side where the throw is going to come out. Railroad the two. Once you have railroaded it, I will just bring it out here. And once this needle comes out, you'll see the loop comes out. It's a single pass. Use just 4 throws and the game is over. So that's game, set and match. I have to also say, Narang had helped in this work so much in this fourth row pupillasty, pioneering it. And once you have done this much here, you can see here, I've done this portion. Now, or if you want, I can also do more on the top portion. Here you can see now the top portion of the fourth row pupillasty being done there. And now you will see the pupil coming back to shape. Now at this stage, if you get a vertical slit like that, you can take a vitrectomy probe. Remember, fluid is all the time going on inside the eye. All I need to do is make it a bit larger. You can use an endodiathermy, which Ike showed beautifully also, or use this. But look at the Purkinje image. It is bang centered. That is the key point which you are looking at. Once I have got this both done, now my next step is, remember, the endothelium was totally bad. So just, I've got air now continuously, the same air pump which we talked about before. I just connect it to the trocar. Now I take my endothelium here. You can see this is the type 1 bubble. So this is the PDEC graft which is present. We never do DMEX because please understand, in DMEC your donors are 40, 50 years. We don't do DSEC because it's too thick. In PDEC you get the advantage of both DSEC and DMEC. We take only young donors. Once we have prepared that, take it into the injector there. Now all I need to do is inject it inside and complete this case. Remember, this was a big shot patient who came to me from Poland. So I had to be very careful that everything goes in one shot, because there was no way he was going to come back to me again from Poland for treatment. Now, once I have got the graft unrolled, my air pump comes on. Once the air pump is on, I've got air infused inside the eye. Now I can just unroll my graft a little bit as much as possible. Now the question comes, how did this patient behave? So let's just see how this case behaved at the end of the day. This is the patient post-operative day 3. That's 3 weeks post-op. You can see how the patient is 2 months post-op already. The patient has improved to 6/6 vision. Saying that, one other case which I thought I'll just show you, and I hope it's seen.
Yes.
Okay, so this patient had another injury patient there, and you can see there, I've just put the corneal suture there. It's quite dense, the cataract. So I'm not able to see very clearly, but still we have brought it out. I know there has to be a rent, obviously, in this case. So I want to be safe. So I'm bringing my nucleus out of the eye. Once I mean out of the bag. Once it's out of the bag, I'm much safer. I've got my air pump on to protect myself from my endothelium. You can notice I've already made my scleral flaps present there for the gluteal, because I know there is a huge foreign body also lying inside through this wound there. Now I fixed my trocar inside the eye. This case, I've done a trocar infusion from the pars plana. I'm doing my vitrectomy, and I'm also removing my cortex at the same time. Now, in this injury case, you notice when I'm doing my posterior vitrectomy, you'll see a large foreign body, and there's a little bit of detachment also stuck there. The whole wooden piece has gone through and through the lens. produced a cataract, gone through the retina. So I'm now catching that, and I'll now bring it out slowly and steadily. Once my intraocular foreign body comes out, and you'll see just now, there it has come out. It's a large foreign body. It looks small inside, but when you bring it out, you realize how large this wooden piece is. And I know Mohan has done a huge piece of a drumstick injury also, which had won in the ASCRS Film Festival. I remember I was the film festival judge at that time, and his video on foreign bodies had won some award at that time. But look at the large piece of foreign body. I brought it, lying it above the iris. Now use the handshake maneuver to bring the long axis of the foreign body in line with the long axis of the incision, and in the long axis of the foreign body in line with the long axis of the forceps. Once the foreign body has come out, you can see there, I now take the lens and I have to implant the intraocular lens inside. That's the measurement. As you can see, it's about 11 millimeter intraocular foreign body present there. I suture the sclerotomy because we have just made it a bit slightly bigger. I do my vitrectomy over the retinotomy to clear the whole fluid which is present there. But now I want to fix my IOL before I fix that retina also. So I make a small iridectomy there. The reason of the iridectomy is will help me so that I can come more anteriorly when I'm doing my glued IOL. Here you can see now the glued IOL coming. So all of you, if you're doing a glued IOL with large white to white, just a small iridectomy will help you, because that small iridectomy will help you come more anteriorly. Now I've done the handshake technique. I'm going to move on to, here you can see the faucet being transferred from one hand to the other. Once both the haptics are tucked in, my next step is I have got the glued IOL in place. My foreign body has been removed. My vitrectomy has been done. But look at the pupil. It's still large. So I need to make that smaller. So again, this technique which we do is the single pass 4th row pupillasty. So once that is done, I make that pupil a bit smaller to complete the case. Here you can see the second part of the haptic getting tucked into the chariot's pocket. And there you can see the second haptic getting tucked inside. You can adjust it. And that's why I like still the glued IOL so much. Now, once I've done that, and you can see now we are doing the 4th row pupillasty, making the pupil smaller. Again, remember, one side you can just go through the clear cornea. I see many people doing paracentesis on both sides. It's very tough to pass the needle through a paracentesis, especially the Prolene needle. So you don't need to pass it through a paracentesis, because remember, the loop is going to come out only on one side, the side where your 30 gauge needle is. So just make one side that, and you can see the pupil coming back to normal. Once you make this pupil a bit normal, you'll see life becoming much easier for this patient, because remember, there's an astigmatism also created by the corneal wound. So here you can see now the second 4th row pupillasty coming out here. The advantage in this compared to cerclage, which I see, is it's much easier and much faster. Whereas with the cerclage technique, which is a great technique started by Greg Ogawa, the problem which I see is a bit more complicated. But if you're good at it, it's fair enough. Once my fluid is coming off, all I need to do is do my endolaser. As you can see there, I'll fix the retina there with the endolaser, and that completes this particular case. And you can see here the end result there. So last thing which I just thought I'll just show you is, if you can see that, that's the latest book which we have brought out with us, 3 of us on it, on mastering iris repair by Slack, which covers all these various techniques which I've talked to you about. So saying that, now I'll stop sharing my screen and shift it over to Namrata and Gaurav and Mahipal.
Thank you very much, Amar. I think fantastic presentation as always, and you always come up with a new idea almost every other month, and that takes the world by storm, and people just latch on to that because it really adds to the scientific knowledge as also the procedural knowledge. I think what is great about Amar is that he knows the science behind as to what he's doing, and then he does a hypothesis and then works out and gives surgical outcomes which are really good. So I think you have several firsts to your name, and thanks, Amar, for being there in Indian ophthalmology and doing India proud as regards the scene of ophthalmic. I think you all know that when there is a list of the top influencers in ophthalmology comes, we have Amar and Abhay being part of that almost every year. So congratulations to them for excellent presentations, and thanks, Amar, for bringing this pupilloplasty technique out.
Thank you.
Anyone has any comments on that?
I wanted to chip in with, yes, Mohan sir, please go ahead.
No, I just wanted to congratulate Amar because this trocar is something which is really fantastic. The trocar assisted hydrodialysis repair. I saw the paper also and I've seen these videos. It's simply phenomenal because it's very, very difficult to get that needle into the corneal end. It's so difficult, and the trocar assisted makes it so easy. And Amar, hats off to you, Amar, for thinking out of the box. It's really lateral thinking. And more importantly, I think every technique of yours, whatever you have developed, is very, very practical and very useful in our day-to-day practice. I think it's really fantastic. My salutations to you.
Thank you.
In fact, I wanted to say the same thing because I used to face a problem 2 years back. I told Dr. Ahmed that when I pass the 10-0 Proline for the single pass 4th row, it sometimes catches onto the lip of the corneal incision. And I think we've got the answer with the trocar, and I think it'll work beautifully well. So I think it's a great innovation, and I'm sure I'm going to enjoy using that. But I think we should quickly go on, sir, if you permit, and we'll invite our next speaker, Dr. J.S. Tityal, sir. Again, he's a brilliant cataract surgeon and always full of pearls of wisdom. He has innovated so many techniques and has huge number of publications as well. And he is going to talk on yet another new topic, which is on intraoperative OCT-guided management of white cataract. So he's done a lot of work on that. Please go ahead, sir.
Just to add,
so you
I
have
think,
to unmute yourself, sir.
Just to add that I think he has the safest pair of hands today in India as regards a surgeon, and people say that until, of course, he does about 100 cataracts a day, his stomach doesn't get full.
Thank you very much, Dr. Mahipal sir and Gaurav, and pleasure to be a part of this conclave. A wonderful achievement from the AIOS part. We talked about various imaging systems. Intraop OCT is also a new thing which we had for last 6-7 years now. We've done a lot of work in various fields, right, from corneal surgeries to refractive surgery to lens surgeries. And I have no financial disclosure that I am employed in All India Institute of Medical Sciences, a premier institute of country, and work in the apex center of the country, Dr. RP Center for Ophthalmic Sciences. White cataract, we all know, does have a lot of challenge in terms of doing a good capsular axis. And most of the time in the intermittent cataract, extension of capsular axis makes things very, very difficult for surgeon. Pre-op examination does help in these cases, CILTAM, which gives you an assessment of the cortex, the capsule, the bulge, the interlenticular pressure, and that can be compounded by anterior segment OCT. But the important thing would be it doesn't give you a morphological features on the table after you do initiation of your axis in these cases. Therefore, intraoperative optical coherence tomography microscopes would give you those dynamicity which can happen during your surgery with these difficult situations, right from a subluxated posterior polar or white cataracts, and gives you a opportunity to classify these cataracts and design your surgical technique according to the morphological feature you see in these cases. So this is our paper on classifying the white cataracts based on our intraop OCT pictures and the changes happening after you initiate the capsular axis in these cases. So we have had a series of cases of white cataracts, and we have classified them in 4 categories, though we do have a spectrum between these types also. So classically, there are 4 types, and the type 1 we have classified, which is seen in a slightly older age group, where you have an OCT picture which is regularly arranged lamellar cortical fibers, minimal intralenticular clefts. You can see one here, but there are no clefts in the anterior part, and the uniform flattening of anterior capsule observed when you inject a viscoelastic anterior chamber. In such cases, there's a very little chance of raised interlenticular pressure as such causing a rexis extension. Therefore, axis is simpler in these cases with the cohesive viscoelastic cover in these cases. Type 2 variety of white cataracts based on IOCT picture, which is seen in around younger age group, where we can see increased convexity of anterior capsule. You can see here. Then we have a continuous hyperreflective cortical band or sheet, which is going across the length of an entire lens. And in between, you have these clefts of fluid, which is beneath these hydrated cortical fibers. In such cases, as soon as you make a nick in the capsule, the entire hydrated cortical fiber bulges out and doesn't allow the clefts to get released, the fluid get released. And these are cases you can have a high chance of a rexus getting extension to periphery. If you see this video here, you have a clefts here and thick sheets. As soon as you make an initiation, the entire cortex bulges out like a hill or a mountain and causing pressure to the periphery of a capsule. There is a high chance that the capsule can go to periphery. In such cases, we make a small opening, keeping the viscoat or a dispersive viscoelastic in periphery. Once we remove the cortical hydration, you can see it's flattening and subsequent rexus becomes simpler. So these cases, because you have a thick sheet of a cortex, needle aspiration may not work in these cases. This is the type 3 of cases where you have convexity of anterior capsule, as well as you have a hydrated fibers, but the length is missing here. You have a broken hydrated fibers and clefts are also there. These are cases, as soon as you make a nick, there's a release of a fluid. So we understand these cases, the release of pressure decreases the intralenticular pressure. Needle aspiration would work in these cases. Similarly, we can make a small opening or wait for some time to get this milky turbid fluid to come out and release the pressure from the behind the capsule in these cases. If you see this video here, you can have a thick oily type of fluid coming out, and with a gentle pressure in the side port, you can release the pressure and flattening of entire anterior capsule, and you can complete the rexus and can assess your pressure and do a spiraling technique, get to a size where phaco can be easily done, and subsequently after completion, you can implant the IOL and you can redesign, refashion your capsular rexus size as per the requirement of these cases. So type 3 cases are simpler than the type 2 cases. So this is one case which is between type 2 and type 3. I was talking about spectrum. You do have a spectrum like this. That this is a case where you have a fluid also, you have a sheets also, you have a clefts also. Such cases with initiation, again, you may have to see what type of pattern you see after initiation. There, I don't see the hill type of pattern coming in these cases. So simply aspiration would do in these cases, and phaco can be completed easily in such cases. So this is a type 4 variety of cases where you have a thick homogeneous fluid collection behind the anterior capsule, which is going towards a Morganian type. But here also you can have a raised pressure sometimes. Sometimes with the milky fluid coming out, the entire capsular bags becomes little loose, and nucleus can be freely rotating in these cases, and rexus become difficult. So you have to have a viscoelastic pressure right from inside the bag and outside the bag to complete rexus in these cases. In femtosecond laser also, as we discussed our posterior polar cataract, same thing can be assessed with wide cataracts also. And we can classify the wide cataract based on an OCT picture. You can see a homogeneous background behind the anterior capsule. You can see here with a little bit of cortical fiber hydration. So there is a chance of raised intralenticular pressure here. Also, you can see here, as soon as we apply the femtosecond laser, the fluid coming out in the breast, that indicates this patient did have, despite having a type 4 type of wide cataract, did have a raised intralenticular pressure. So in such cases, after aspiration of fiber, you can see these are fibers which are still seen. So this was between type 3 and type 4 type of wide cataracts. So these varieties can be nicely assessed with intra-op OCT and can give you the dynamicity which happens after injection of viscoelastic before initiation of a capsular rexus, or after initiation of capsular rexus, what happens and how to avoid these circumstances to decrease the complication happening in these cases. If I summarize, this was a spectrum of wide cataract in these cases. Type 1 is simpler, seen in around 18% of cases. Type 2, which is difficult, seen in less number of patients. Type 4 and type 3 are seen in a larger number of cases in these cases. So I can understand type 2, if you see those type of cases, you have a slightly higher chance of rexus getting extension to periphery unless you take appropriate measures during your initiation of capsular rexus in these cases. Type 3, type 4, needle aspiration of cortex or exchange with viscoelastic or doing a small capsulotomy will help in these cases. So all wide cataracts are not similar. You have to understand the clinical picture in the pre-op examination with slit lamp or anti-segment OCT. Intra-op OCT does give you a lot of help. And this particular video, we have won the Best of Show Award in American Academy in 2018. Thank you for your kind listening.
Wonderful, Tityal sir. I mean, it was like a masterclass in handling white cataracts and the categorization and how to, go about it. Very good learning for anybody who's doing, cataract surgery, and phaco surgeons would love to hear this. I'll take quick comments from Ron and Dr. Himanshu. Ron, I know you have a passion for these things.
Yeah.
Please go ahead.
Thank you, Gaurav, and thank you very much, Jeevan. I loved your presentation. I have a particular interest in the use of IOCT like you. Have you compared the IOCT images with those from the Flex machine and say UBM in terms of, how reliable and how comparable they are?
Yeah, thank you, Ron. I know that you have been working on IOCT for quite a few years now. Yes, we had compared the entry segment OCT pictures and femtosecond OCT picture and IOCT pictures in posterior polar cataracts and some of white cataracts. So mainly our focus was in the posterior polar cataract, and this has been published also in JCRS, the different types of morphology of posterior polar cataracts. And we have found that entry segment OCT and IOCT matches almost significantly quite well, because the imaging is far, far better. While femtosecond laser, you can delineate the posterior capsule and posterior polar cataract. That can tell you if there's a defect or no defect. But it cannot really classify the various types of posterior polar cataract, which we think type 1, type 2, type 3 in terms of clarity in a central and peripheral part of posterior capsule. But it does give you the assessment of open posterior capsule or an intact posterior capsule. But anti-segment OCT and IOCT really matches very well. Therefore, people who have access to anti-segment OCT, they can very well classify their cases pre-op and take a precaution in an intraoperative way also.
I must say you had very nice images, because my impression has been that when the cataract is fairly opaque or dense, the quality of the imaging within the lens usually degrades very rapidly.
But whatever we now here have a high definition intraop OCTs also with the newer generation microscopes, and does give you a very nice pictures. And I know that now entire our OR system, nobody operates without IOCT microscopes. So that's I think learning for younger generations also to know what is happening during their surgery. Especially now we are shifted to a off microscope 3D system surgeries, where you have a better assessment of both intraop and OCT picture together in a larger screen. That also helps assessment of your cases much better.
Indeed, thank you.
Also, you're raising the bar by saying that now everybody operates with the OCT assisted microscopes. I think you're making life tough for everybody else. But I think, quickly from Dr. Dhami.
Not for the young generations. Not for young generations.
Dr. Dhami has published on, yes, Dr. Dhami has published on similar, OCT on the, anti-segment OCT for this thing. Quick word from you, sir, and then Dr. Himanshu, and then we'll go on. So you have to unmute yourself. Dhami sir, we can't hear you.
You have given us a very good understanding and a clarity. Definitely, all of us don't have intraoperative OCTs, but your presentation gives us what to look at an anterior segment OCT and what to look at an AIOS 700. Both serve a very good purpose. I was added to, as Dr. Mahifal said, a clinical examination of slit lamp does matter a lot. It will give you the bulge, it will give you the thickness of the fluid, it will give you the type of the fluid. And an average surgeon will know when not to puncture and when to shift to a different technique. Thank you, Dr. Tidal. It was a wonderful presentation.
Thanks, Dr. Dhami. And Dr. Himanshu, a quick word from you.
Yeah, thank Gaurav, but no greater words of praise than that. Raising the bar every time, you speak to Dr. Tityal, gives you that lovely complex that you have to raise your bar always. Well, the point is, even if you do a femto in a white cataract, it can give rise to extension to the periphery, rarely. But one thing that I would want to mention is that even if it goes to the periphery, continue with your rexis and go ahead and do your phaco. It's not that it is always crossed on beyond the zonules. That's the only thing that I would like to add on to this. Of course, the presentation, fantastic. And the standard norm for every white cataract would be to debulk it with a small rhexis with your needle and pull out the fluid. I think that's the standard norm going further ahead without questions.
Thanks, Dr. Himanshu, and I think we'll go on. In fact, I wanted to just add that a slit lamp examination can also really tell you a lot about, if you make a proper slit and good examination, it can be a good substitute for those who don't have an OCT, and I've actually spoken on that topic. So I have shown images comparing OCT and slit lamp, and they kind of match up pretty well because they're basically on identical principles. But excellent talks, and I think we'll invite our next speaker, who's none other than the president of AIOS, Dr. Mahipal Singh Sajdev, a dear friend and a mentor, and who has really pioneered in ophthalmology in India, and has done an amazing job during his year as president of AIOS with lots of unique activities that we've had and fighting the COVID pandemic. Mahipal sir is speaking on flax for challenging situations, and he's again a pioneer in femto-assisted cataract surgery. Please go ahead, sir.
Thank you very much, Gaurav, for your kind words. Am I audible and everything is fine?
Yes, sir. Yes, sir. Please go ahead.
Indeed, a pleasure to have such international galaxy of speakers here. So I would say good morning, good afternoon, good evening, good night to everybody who is from various time zones. Well, I'll be talking about my present passion, and that is the use of the femtolaser assisted cataract surgery. Femtolaser cataract surgery, even in routine cases, is something that has caught on, at least in the Delhi NCR capital. And today we are doing about 50 to 60%. In my personal cases, maybe 70 to 80% of my cases are being done by the femtolaser. But the advantage of the femtolaser comes into play when you're looking at complicated and challenging cases. And that is where you need to explore the power of femto as to how it helps. I have no specific financial disclosures for this particular talk, though I am a consultant for J&J, whose machine I'll be talking about. Well, femtolaser cataract surgery is, as I would say, a tool for the routine, but also to simplify the challenging cases. And something that has been talked about earlier is is my passion for doing femtolaser, as Mohan said, in all posterior polar cataracts. And even if there is a pre-existing weakness in the posterior capsule, the cortical cleaving hydrodissection, if done, which was done earlier, can cause hydraulic rupture. But the femtolaser assisted pneumodelineation that happens, it totally eliminates the need of doing a hydrodissection or hydrodelineation. And the disassembly of the nucleus, as was described by Abhay about concentric rings or segments, they can simply simplify. And this was the paper that was published regarding the femtolaser integrated anterior segment OCT to detect pre-existing capsular rent in Journal of Cataract and Refractive Surgery. And as you can see here, the conclusion was that femtolaser with integrated AS-OCT is relevant and a helpful tool to detect and increase the safety margins. And this is what is very, very important that is there. I'll just show you that pre-operative imaging is what we are comparing with the intraop OCT just now, and in a thesis for a DNB student, and the results would be out soon. But here what I'll just wish to show you is that, again, what has been shown is that this is clearly, you can see that this is a clear defect which is there. There is no posterior capsule which is there, and these bubbles that you get onto the catalyst system, you just have to raise the default setting, because you can see here that these default setting, and you have a clear area where you would not be doing anything to the as regards the femto, and you can see the ease of disassembly that you can have. And this is the posterior capsular rent that happens. I would wish to differ slightly. I normally do not, whether if I make it a posterior capsular excess, because these defects are vertical transactions which happen and they are pretty large. And I have had cases where the IOL is not stable. So I normally prefer to do a sulcus implantation with a 3-piece lens in this. So in this complicated case, of posterior polar, the femtodelineation definitely enhances the safety. The softening of the nucleus can help tackle even harder nucleus, as you saw in the previous case. And a perfect CCC is good for sulcal implantation. Kiranjit was talking the other day, he is describing the oval capsular excess, and he thought, and I think it wouldn't be difficult to get an oval capsular excess if somebody wants, you can have the machine give you an oval capsular excess, because they will have to open the software and allow you the same. Now, this is a picture of the Malugan ring that you can have for doing femtolaser assisted cataract surgery in a small pupil. Now, this is often sometimes said that you can't, obviously you can't do a femto laser until of course you have an adequate pupil. So if a pharmacological dilatation is not possible, you can do a mechanical delineation or a mechanical dilatation of the pupil that is there. Now you can see in this particular case, you will have to go in and have to come back to the laser machine. So that is something which is important. So this is a Malugin ring that is being used. The pleasure to have Dr. Boris Malugin also in this session. And this again is a great innovation. So you can see that you get an absolutely well dilated pupil. You can wash away the viscoelastic and maybe put a suture, or you can increase the energy level, and you can see that this is a good capsulorhexis that is being done. There is a dissection that is happening in this particular case. So you can see that we have in a small pupil a good rhexis that can happen in these cases. Dr. Tityal showed it as regards white cataract. The basic advantage of doing a femto in a white cataract or in intumescent cataract, in this particular case of phakomorphic glaucoma, is that you are working on a closed chamber. So you can see the swelling of the lens which is there in this particular case, and you can see the crowded anterior chamber where you have the iris almost, you can see that it's a block. And again, you can see that there is a gush of fluid that is coming out because it was so much liquefied. The important thing in all these cases is that even if you feel that there is no tag, you should always use trypan blue, because inadvertently there will be some tag which will be there. And the trypan blue will help you take care of that removal of the tag if at all that is there. Now, this is a rock hard cataract, mind you. This is a grade 4, grade 5 cataracts. I think David Chang also shows some of these cases where he goes on to SICS. Now you can see in this particular case, the advantage of the femto, you can see that the cleavages have happened pretty well, and look at the color of the nucleus that is there. So harder the cataract, the more advantageous it is, as long as it is not white. If it is white, you don't get exactly good cleavages which are there. But if you have a cataract through which you can, a slit lamp can see, so similarly a femto can go and penetrate through that, and you can see that we get good outcomes. Now, when you come to post-traumatic subluxations, that is an important area where you can actually use the power of the femto. The power of the femto can be used in doing a capsulorhexis, which you can decenter, which I'll be talking about, so that it becomes centered after you put the ring. Now, this is the case, as you can see. In this particular case, you can see the going backward of the iris. Can you see this iris? And it is going backward. So there is a subluxation, and there is, if you look very minutely, there is vitreous that is coming onto the top. So there is a subluxation with vitreous which is coming, and what we have to do is that the machine will not give you on the auto the posterior and the interior capsule, so you have to bring it back. Now this was on a scanned capsule that you have, but we go on to a manual. I'm just going on a fast forward. In this particular case, we are using the pre-planned posterior approach. In this particular case, putting tricot, you went in with the posterior approach, did the vitrectomy to remove this with tricot, putting in endocapsular ring in this case, and you can see that the chopping has actually softened the nucleus pretty much, and without much intervention, you are able to bring out the nucleus with the power of the femto that has happened. Bimanual irrigation aspiration will help you in reducing, and then you have to actually peel out the cortex because there is an endocapsular ring which is already there. And once you have done this, keep the infusion on, as is important, put viscoelastic, additional support to the capsule with a 3-piece intraocular lens, and again you can see if there is any vitreous tag or not. And this is the post-operative condition that you have in this particular case. So friends, all that I wish to say is that there are various indications for the femto machine that can help you in these difficult and tough cases. Obviously, this is not the last part. There are several others. You can do it in the pseudo exfoliation, gives you a good capsulotomy. Whenever the capsule is not giving you a good adequate support for doing a capsulorhexis, white cataracts, hard cataracts, as I told you, posterior polar cataracts. So things become much easier, and specifically it hastens up. One of the things that is being said about femto is that it slowers you, but I actually, if you have a teamwork, you can have somebody else doing the femtos outside and you doing the procedure inside, or vice versa, and that actually speeds up the procedure. And my time has actually gone down by about 40% as regards the entire thing spent as doing multiple cases. So I think friends, as the only thing as is the technology, it is becoming cheaper. In due course, we are also having the Cassini, which should be introduced in India, where you can have a good alignment of the steep axis, which is there for LRI correction. I think if the LRI nomograms become better, then the LRI will give you better outcomes, and you can correct astigmatism of smaller degrees without the need of going in for a toric intraocular lens. I think if the cost per procedure goes down, it is going to be the standard, the gold standard, I would say, over the next couple of years as the procedure of choice for cataract surgery, and specifically for cataract surgery where you have issues of complications or difficult situations which are there for handling. Thank you very much for your kind attention.
Thank you, Maipal sir, and for showing those amazing cases where the femto can have. And I fully agree with what you said. And I'll now take opinion from Dr. Mohan Rajan sir, who has a lot of experience with femto-assisted cataract surgeries in these challenging situations. Would you like to chip in with your hard cataract?
I fully endorse whatever Maipal said. Femto is not only for complex cases, hard cataracts, subluxated cataracts, posterior polar cataracts, white cataracts. But I feel femto, if you have the access to femto, and the patient can afford whatever he can. But even for softer cataracts, patients are coming with 6'9", 6'6" vision. You don't want to make any mistake in that. Okay, you want to be very, very safe. So okay, the safety of the procedure is very, very simple and is much better than the your manual phaco. And that is what I tell the patient. When I tell the patient, my hands are 100% safe, but you want 150% safety, then probably go for femto. The patients are convinced about it. And we have got the results. For example, patient who got a corneal endothelial gutta with a hard brown cataract with the femto works much better because the energy I'm using is about 30 to 40% only of the original energy if you use the femto. So because there's a pre-cut, everything is available to you. The rhexis is there. Intermittent cataract, the rhexis makes life easy. Only thing is in intermittent cataract, please beware of the skip areas, because skip areas, so you cannot have, most of the times you don't have a free floating rhexis. Otherwise, all the cases you have a free floating rhexis. Mature cataracts, you can have skip areas, so you have to be a little careful. Don't try to pull out the rhexis. Always try to do make sure the attachments are pulled off very, very carefully. So these are the things I want to add for Maipal's wonderful presentation.
Thanks, Mohan sir. And I now ask Dr. Dhami why he still hasn't, started doing femto-assisted cataract surgery. Dr. Dhami, would you like to comment on that?
Yeah,
I don't know. I think
No. Listening to Maipal, I think it's better than late. Start immediately. But definitely, femto has a role. Not only simplifying the tensions you have, giving a good quality of surgery to the patient. And I think if the added costs is decreased, femto will be the choice surgery for everyone.
Thank you so much, sir. And I see David Chang is here and Dr. Rohit is there. So David, if I don't know whether he's hearing us, but David is a strong, welcome David, and it's so good to have you here. And I thought this is the best time to rope you in because you've been talking on Zepto and femto and those debates and what we've attended in the ASCRS. I would love to hear you chip in with your views on femto versus Zepto versus the capsule laser and what you think is the way ahead.
Good morning, sir.
Good morning, everybody, or evening, and great to be here. I think these are all just great options, that we have options to help people with these different steps of surgery. And I don't think there's any way we can say this will be, the standard or this will be superior. Certainly the evidence is hard there. I think it's just that we have options, and ultimately the surgeon decides, what way to give the patient the best results. And, I think we respect whatever that is. Zepto is relaunching. They've totally spent the last half year redoing their whole system because the initial one out of the gates, was really the first try. And the company's actually relaunched. And I had the opportunity to try the newest version 2 weeks ago. And without going into the details, it's really quite an improvement. So it's much more consistent, and I think the Rexus will be stronger. So I think we should just welcome that as an alternative, because cost is a barrier for many patients, and it's nice to have options that can improve acceptance and availability. But I personally just still do my manual capsulotomy, and but that's really just me.
Thanks, David. And I completely agree what you said. But, I think what I've learned over the years is that femto has been a great tool for the complex cataracts, the challenging cataracts, and it has an amazing role. And yes, in your hands, you can handle anything with so much ease. But for other surgeons, I think it might have a role. And I know that Dr. Rohit Omprakash for 3 years was not ready to buy a femto-assisted femto platform after he had kind of returned his first one. And then, he was a strong proponent in every debate that, femto is not required. And then I convinced him. And now I think, Dr. Rohit, are you happy with your new acquisition and enjoying it?
I think the second avatar has been much better than the first one, because the technology.
I totally agree, yes.
Yeah, the technology has improved, and I think it's high time that wherever, because there are certain indications where it really helps. And the patients are also demanding courtesy, Dr. Mahipal, because he has given so much of flip to this in the whole North India that people are coming and demanding it. Leaving aspect the commercial part, the surgical part has also eased. The time period involved in the surgery has also decreased, and the efficiency is also
absolutely.
I think
I'll request Namrata to
invite
the next one. Yes, please, Namrata. You want to invite the next speaker?
No,
Dr. Rohit Omprakash is the okay. So I think Dr. Rohit, you have the baton already, and understanding and decoding IFS. Dr. Rohit Omprakash needs no introduction. He's a fantastic phacosurgeon, and also the organizer of the Winter IRSI meeting from Amritsar. Please go ahead, sir. He has so many innovations that he's published. This is another.
Thank you, Dr. Gaurav, for the kind words. So I would like to thank Dr. Namrata for calling me over in this beautiful session of hers. I would be talking today about understanding and decoding intraoperative floppy iris syndrome. Well, we have to give credit to David for this innovation, for discovering it and unearthing it. For those patients who have been using alpha-1 antagonist drugs, specifically tamsulosin, all across the world. So IFIS usually presents with three things. First is there is iris billowing and fluttering. Second is there is progressive constriction of pupil, and there's a tendency for the iris to prolapse through the incisions. I would like to show how it happens. There is, when there is billowing, there is touching, there is progressive pupillary constriction, and iris prolapsing through the incisions. Well, the IFIS occurs in the general population in the study which was conducted, occurred in 1.1% of cases, and more so in patients who have been treated by systemic alpha-1A adrenoceptor antagonists. More so, and the incidence of intraoperative floppy iris syndrome, or the flop wherein there is a floppiness of the iris.
There are no financial disclosures in the subject matter.
57% of eyes. Well, the patients have a large pupil challenge. These pupillary challenges are preoperative as well as intraoperative challenges. The first and foremost which we see is that there is a reduced maximum pupillary size diameter. So in these patients, the maximum pupillary diameter is very often decreased. Second, what we have to bear in mind is that there is a weak dilator tone, subsequent to which it takes a longer dilatation time for the pupil to dilate to its maximum capacity. Moving on to the next part is that we have to know that the preoperative pharmacomedriasis has also to be planned in these patients. Well, this has to be based on either the parasympatholytics or the sympathomimetics. Well, the parasympatholytics are in the form of atropine, cyclopentolate, and tropicamide. Well, they have an indirect action by inhibiting the iris constrictor muscle, whereas the sympathomimetics have a direct action, like the epinephrine and the phenylephrine, direct action by displacing tamsulosin and increasing iris tone. Well, one thing which needs to be borne in mind is that once the muscle atrophy occurs because of prolonged usage of alpha-1 antagonist drugs, the efficiency of dilating the pupil decreases. So this is one thing which needs to be borne in mind. The NSAIDs have a direct role, have a very important role when it comes to sustaining the pupillary dilatation. The first and another important thing which we have to bear in mind is that the dilatal muscle region is thinned out and atrophic. This is as compared to a normal patient who does not use any alpha-1 antagonist drug. So here you would see that the muscle is thinned out and atrophic, subsequent to which, whenever there is excess of fluid to the posterior aspect of iris, you will find that in this part, the iris was billowing. Whereas in a normal patient with a normal strength of the dilator muscle region, there is less of iris billowing. Well, the next point which has to be seen is that in these patients, in normal patients, the pupil dilates with mydriatics, have a strong dilator muscle action. But whenever there's a trauma to iris, it causes minimal pupillary constriction. Why? Because the constriction power is less than the strong dilator muscle strength. So that is not able to overpower the constrictor muscle action by any means. However, whenever there is a repeated trauma, it still doesn't, because you will find that it is not barely equal on both the sides. And the pupil constricts, but to a minimal. But if there is a repeated trauma, then the pupil constricts. However, in patients who are using alpha-1 antagonist drugs, the case is different because there is an exaggerated response to iris touch. Why so? Because the dilator tone is weak. So if the dilator tone is weak, a small touch produces exaggerated response in the form of pupillary constriction. So this is another thing which we need to bear in mind. So next is, so this is, pharmacological. This is a study which was shown in JCRS, pharmacological pupil dilatation as a predictive test for the risk for intraoperative floppy iris syndrome. It was seen that for a pupil 7 millimeter, even 7 millimeter or slightly smaller have an inherent risk for IFIS exists regardless of alpha-1 antagonist treatment, which surgeons definitely should take into consideration. Here, again, I would like to give David the credit, wherein he has used Malignant ring pupil expansion device for intraoperative floppy iris syndrome. So there is no second thought that we are able to have a constant 6 millimeter pupil diameter throughout the surgery. And there was no significant intraoperative or postoperative complication, mark my words, despite the fact that 93% of the eyes had moderate to severe IFIS. So dear friends, using pupil expansion devices does help, but then you need to have techniques to decrease the incidence of moderate to severe IFIS. Let's see the stepwise approach in these patients. The first and foremost is, what we should bear in mind is that the tunnel, as Steve always says, has to be long and anterior tunnel. Because if we have a short tunnel, we can have iris prolapsing through the ports. Calibrated side port incision is something which I have always been talked about. You will see this is a patient who has been using tamsulosin for 15 years. You will find that there is no iris billowing. And because the incision is calibrated, what I am doing is I'm calibrating my side port incision with the side port chopper, wherein with the 25 gauge needle, it is 500 microns, whereas the chopper which I'm using, it is 400 micron chopper diameter at the distal end of the shaft of the chopper and 450 micron at the proximal end of the shaft. Now, what is happening with this is we are calibrating it, and this difference in 50 microns or so is for preventing distortion. You will find how there is not much turbulence around the side port incision and in the whole procedure, because if we use a non-calibrated side port incision, here I would like you to see the pupil is normal here, but because of the discrepancy in the side port incision, What is happening is that this is being initiated because of non-calibration of site potency and the IFIS being, initiated. This I have seen in so many videos across the world where people are not calibrating the the site port incision. Pharmacomedriasis I have already talked about, but here I would like to re-emphasize early stages it helps, but in advanced stages it doesn't because of the atrophy of the muscle. So this is before and after, mark my words, it is. But if by any means, if the pupil size is between 3 millimeter to 5 millimeter, pupil expansion devices are a must. Steve, again, I would like to compliment how he has helped in IFIS by putting forth the Arshinov, tri-soft shell technique. This is viscodispersive, which flattens and slightly dilates the pupil, viscocohesive in the center, then BSS goes behind. But the most important thing is what we have to bear in mind is we have not to overinflate because we can end up with iris prolapsing through the incisions. Sizing of capsulorhexis is also very important because by all means, we do not want excess of fluid in this area. So if the capsulorhexis shield is there and it doesn't allow fluid access to the posterior aspect of the iris in the mid-peripheral region, we will not have IFIS or billowing of iris initiated. So capsulorhexis sizing has to be slightly on the smaller side in these patients. You can use a cystotome also, and whatever suits you suits the purpose as well. The next point is hydrodissection. Don't be overzealous because if you are, you can end up with a situation of having IFIS. Fluidics, low fluidics, because you don't want iris turbulence. Continuous irrigation has to be off because if continuous irrigation is on, you can have a situation like this because there is a high AC IOP, and when you come out, there is prolapse of the iris. Nuclear emulsification is very important. What I do is I use low fluidics, but the most important part is leave the nuclear pieces in situ. Why we leave the in situ? Because that helps in having a stable AC, and it helps a situation where there's less excess of fluid to posterior aspect of iris. So this is another thing which needs to be looked into while doing nuclear emulsification. The next part is, in these patients, you should divide your pupil into two. And while emulsifying, if by any means you have to use high fluidics, keep it in the proximal part. That will help you, not emulsify the iris by any means. So this is what should be borne in mind. And continuous replenishing of visco also helps in these patients. The next is irrigation and respiration. I would like you to see that for those who use a coaxial, retract it. When you retract it, this is one plane of irrigation and that is the other plane of aspiration. So you are creating a situation wherein you are having different plane of irrigation and aspiration in these patients. See how diligently I'm using my vacuum. When I'm below the iris, behind the anterior capsule, the vacuum is low, and when I'm holding it firmly, then only I'm increasing this. So there has to be an advantage of having two levels. If you are using bimanual, that makes life definitely much better in these cases. In our series of cases, we did not have even a single case of moderate or severe IFIS, and that too for the last so many years. It is somehow something we have never seen, moderate or severe IFIS. So decoding, we should know the technique. Atraumatic surgery, decrease excess of fluid to posterior aspect of iris. You should use calibrated side port incision, use sympathomimetic drugs, OVDs to manage, and viscomedriasis is very important in these patients. So summing up, no predisposition in patients using alpha antagonist drugs. Use pupillary dilating aids, but definitely know the technique. Because if you know the technique, you will be able to avoid so many things by using calibrated side port incision, sympathomimetics, and OVDs to your advantage. Trifles make perfection, and perfection is no trifle. Thank you very much for the opportunity.
Thanks, Dr. Rohit, for that wonderful talk. And since we are running behind schedule, I'll restrict our discussions here. We still have amazing talks coming up in order by Dr. Rajesh Sena, then Ron Yo, then John Chang, David Chang, and Boris and Chi, and more. So let's quickly rush through our excellent talks without wasting time on discussions. I'll invite Dr. Rajesh Sinha to please start immediately with his talk on phacoemulsification in silicon-filled eyes, and we will have time for discussion later on all these talks.
Thanks, Gaurav. And I'll be talking about cataract surgery in oil-filled eyes. I don't have any financial interest. We know that cataract formation is a common complication of partial vitrectomy, and as the vitrectomy is increasing day by day because of the improved technology, the cataract surgery will also increase in these vitrectomized eyes. There are various factors responsible like intraocular gas or use of silicone oil or direct instrument touch, then progression of senile cataract. Most of these are diabetics. They undergo VR surgery. There's progression of cataract, and there are a combination of factors. And there are various challenges when you're doing phaco and oil-filled eyes, like there's high risk of complication due to residual effect of previous surgery. There's increased risk of post-op inflammation. There can be emulsified oil in anterior chamber. There can be presence of posterior capsular plaque, or there can be presence of pre-existing posterior capsular defect. And since all these procedures, the vitreoretinal procedures are lengthy procedures, so there is risk of damage to zonules, and that has its own problems in terms of loose capsular bag and other issues. Then there are some other challenges like fluctuating anterior chamber depth caused by increased movement of the lens iris diaphragm due to lack of vitreous support. There's infusion deviation syndrome that has been reported in these cases. Fluid migrates posteriorly, you raise the bottle height, further pressure increases, fluid further goes posteriorly, and then what happens is that the chamber starts becoming shallower, there's risk of iris prolapse. So all these things can be taken care of if we plan our surgery nicely. We should figure out the posterior capsular status preoperatively. We should delay surgery if the cataract formation is rapid, because if somebody has undergone a vitreoretinal procedure and there was a sudden increase in cataract formation, sudden cataractogenesis and progression, this means that there is a posterior capsular defect due to the instruments. And so you should delay the surgery so that the margins get rigid, the margins of the posterior capsular defect, they become fibrosed, and then the risk of nucleus falling behind is lessened. Then one should use viscoat during surgery. It helps in coating the zonules because there can be some zonal defect because of the prolonged surgery. And one should use a low setting as far as the procedure is concerned. Apart from all these, as you can see here, this is an oil-filled eye wherein the cataract surgery, the routine chopping technique is done. Then you can have posterior capsular plaque, and if you see that it's in the mid-periphery and there is no cleavage plane being created, then it's better to leave it like that. I prefer putting endocapsular ring in most of these cases of these vitreoretinal surgeries because of the chances of some degree of zonular damage in these cases. Now, as you can see here, this is another case wherein the posterior capsular plaque is there. There's a nice thick posterior capsular plaque, and you can create a cleavage plane. So once you have a cleavage plane, then you can lift these plaques and remove and clear the visual axis completely. But there are situations wherein you can have a large plaque which is actually, merging with the posterior capsule. As you can see here, there is a large plaque, but it's actually the posterior capsule that is opacified. So in such a case, and you can see the capsule is so taut because of the silicone oil that is filled inside. So it's not advisable to do a posterior capsular opening here because the oil will come into anterior chamber, the whole procedure will become messy, and even the posterior capsular defect can extend peripherally. So in such a case, it is always advisable to remove this posterior capsular opacification while doing the silicone oil removal. You can put the intraocular lens, and subsequently, once the oil is being removed, then it can be done. Now, this is another case wherein you have a pre-existing defect, damage due to the instrument, but it was an oil-filled eye, Normally, if it's a fluid-filled eye and you have a damage in the posterior capsule, then there is a fast progression of cataract and the cataract becomes total. But if it's an oil-filled eye, what happens because of the meniscus that is there, closing the posterior capsular defect, there is no fluid that enters into the lens, and that is why perhaps the progression of the cataract is not that fast. So as you remove the cataract, oil will keep coming. So in such a case, I prefer putting a multi-piece IOL. I prefer putting a multi-piece IOL and do an optic capture. So multi-piece IOL, haptic in the sulcus, and optic capture. Once you have done the optic capture, then what happens that it closes, it seals the posterior capsular defect also, and there is no oil that keeps coming into the anterior chamber. Then you can have oil in the anterior chamber in all these eyes, so you have to remove the oil, and then you can go ahead and perform the procedure. Femtosecond laser surgery is very much feasible in cases of operated VRs. In this case, you can do a femtosecond laser procedure easily because there's no oil in anterior chamber. But if you have an oil in anterior chamber, then in that case, because of shadow, it doesn't cut the capsule properly, and it doesn't even emulsify. It doesn't even cause the nuclear fragments. But you can go ahead and do a femto procedure if you have oil or synechiae in the anterior chamber, because these days, although I don't advocate, I would prefer doing a manual procedure in this case. But if some patient comes to you, after reading in internet and he wants a femtosecond procedure, then in that case, you can remove the oil, release the synechiae, inject high viscosity viscoelastic, and then after that, you can go ahead and complete the femtosecond procedure. And like this. The only thing is that if you have injected high viscosity viscoelastic in an anterior chamber, then in that case, you have to use higher energy for the procedure because of the high viscosity viscoelastic. So and in such cases, there is always the chance of skip areas. So you should stain the capsule and then complete the procedure. We performed a study comparing flax versus conventional phacoemulsification in oil-filled eye, and the rationale of the study was that, as I said, that there's a risk of compromised zonules and loose capsular bag in most of these cases. So whether flax will have a better outcome in comparison to femtosecond laser, and we found out that the cumulative dissipated energy was significantly lesser in flax group, and the specular count again. The endothelial cell loss was also significantly lesser in flax group. As far as the total duration of the procedure is concerned, the flax group definitely entails 2 procedures, so it had a longer time. However, the phaco time in the flax group versus, that is step 2 of flax versus conventional, the procedure was faster in flax group in comparison to conventional group. And in 40% of eyes wherein there was no oil in anterior chamber, some oil came, a little droplet came into anterior chamber while doing rhexis or while entering into anterior chamber when performing conventional procedure. But since the flax is a closed chamber procedure, so none of these droplets came into anterior chamber. And as we know that, oil droplets coming into anterior chamber, touching the endothelium may have some implications as far as the endothelial cells are concerned. So there are, in conclusion, there are various issues that I would like to highlight in cataract surgery in oil-filled eyes. There are 4 major issues. One is there's presence of plaque, so you have to decide about the management of the plaque. There can be pre-existing defect, that is important. So you have to be careful in timing your cataract surgery. There can be zonular dehiscence because of the prolonged VR procedure, and then you have to be ready with all your gadgets to strengthen the capsule, to strengthen the zonules. And of course, there is risk of infusion deviation, so you have to keep a low setting, and you have to be really careful that if the chamber is becoming shallow, don't keep increasing the parameters. It requires a very good preoperative planning and accurate IL power calculation and a meticulous intraoperative manipulation. So thank you very much for your patient listening. I'm ready for any question.
Thank you, Rajesh, for that excellent insight into phacoemulsification in silicon oil filled eyes. And I think we'll invite the next speaker because we have a whole lineup of speakers now. Dr. Ronald Yu, who again needs no introduction, from Singapore. He's going to be talking about imaging of the posterior capsular new sign. And of late, we've heard him a lot on intraop OCT microscopes and phacoemulsification surgery. So I'm sure it is going to be, again, some exciting new sign, which is going to give us more insight into the way we do the cataract surgery.
Okay, hello. Hello, everyone. Hi, Namrata, Jiwan, Mahinda. Thank you so much, Mahipal. Thank you so much for inviting me to join this wonderful AIOS session. Well, I'm going to be sharing with you my thoughts on the IOCT imaging of really mainly the lens capsule. And Namrata, I know you made a presentation on this a day or two ago, and I'm sorry I missed your talk. I hope I don't overlap with you too much. But I've been having such fun really learning about this new imaging technology during cataract surgery. So I thought I'd just share this with you. Now, the IOCT is actually a lovely instrument. We can see, as you can see here, the anterior capsule beautifully. You can see the anterior cortical cataract beautifully. And if you focus behind, we can see the posterior capsule and also the posterior subcapsular cataract very nicely. I also love these images of live hydrodissection, and you can see here the fluid wave coming in here on the right, really showing us the different layers of the lens. And I mean, we're still learning about this new technology and what all these things actually mean. Here's a patient with a phaco tip in the eye. You can see there's a layer of cortex on the posterior capsule, which was being pushed back. Now you see that the whole posterior capsule has come forward through the holographic image of the reverse cornea. You can see that the posterior capsule is bulging forward, but when I put the IA tip in on the left, you can see that the posterior capsule now bulges backwards with that layer of cortex. So really the technology is pretty good at imaging the posterior capsule as well, as long as the lens is reasonably clear. I mentioned that earlier, that in a very dense, opaque cataract, it's sometimes hard to see the deeper layers, but when you've taken out the cataract, it's usually quite easy. Now, I think just now we talked a little bit about how important IOCT is, and I don't think we're there yet, but I think that it is going to be more and more useful, certainly in teaching institutions, for teaching residents, things like how deeply to sculpt the nucleus, what the incision structure looks like when you're using OCT. It's also pretty useful in doing research, like looking at the IOL capsular back relationships, whether to remove OVD or not. But really, it's in the field of as a surgical aid. Is IOCT any use as a surgical aid? And I actually particularly wanted to look at posterior capsule ruptures. Now, some of you may not know what a PCR looks like. I teach many residents, so I have a pretty regular view of PCRs. But my IOCT, unfortunately, was in my private practice, So, and I wanted to sort of image what the OCT view of a PCR was. But so for the last few years, I didn't have a PCR, so I had difficulty imaging the PCR. So finally, I had a case in which I decided to do a primary PCCC because the posterior capsule is very dense. And I thought this way I could image what a posterior capsule rupture actually looks like. So here's my needle, just making a simple tear in the posterior capsule and turning on the live OCT here on the right. Once we've done that, and we should see here, now you can see actually the posterior capsule defect is beautifully shown here. And we can see that the edges of the defect are both turned backwards, beginning to fold back on itself. And so I was very pleased that we can actually see that. And here, the way we line behind is actually the hyaloid face, but we can actually see the posterior capsule rupture quite well. So, and when I got that, I was saying, gee, okay, now I know we can see the posterior capsule. Let's wait for a real PCR rupture to happen. And of course, having commented that I haven't seen a PCR for a few years, then I had a run of a few. Let's look at this case in which I'm injecting a toric lens into the eye. So the toric lens has gone in, and I always go behind the lens to remove OVD. And here you can see my IA tip has gone behind the lens. I'm just aspirating gently. I'm really not doing very much. And then as I come out, I see that line there. Can you all see that line diagonally across that? I don't know about you, but I feel I never get PCR. So surely that can't be a PCR. I mean, I didn't do anything wrong. So I put the lens in anyway. And by this time I realized that it was a PCR and I've captured the lens. But here we can see that I've done an anterior optic capture. So one use of the OCT is that the optic is behind the anterior capsular leaf that you see there. And then I'm going to bring the OCT over to that diagonal line behind the lens to see if we can see it. And here you can see the sign that I'm talking about. You can see that there's a scroll, that the posterior capsule, the edge of the PCR kind of curls up like a little scroll there. Okay, and if you notice that what I showed you just now with the anterior capsule, because you've got a nice round anterior capsular CCC that's intact, the edge doesn't roll. The edge is actually completely straight. But when you've torn the posterior capsule, you get this scroll-like image. Having got that one, shortly after that, here's another one. Okay, I think this was actually the new synergy lens that I was putting in. I was also going in behind the lens to remove the OVD. And if you can tell me why this capsule ruptured, I'd be very grateful. So I was just aspirating behind, come forward, and there's another line, okay? You see that line there? There's a line up there just under my IA tip. Again, I thought, gee, wow, good things certainly don't come alone. So, looking at that, I put the lens in, and I'm just turning on the OCT now. Now, this one's a lot more subtle than the previous case. Where you look here, on the bottom right, you see there's that little scroll, that little curved edge. Now, using the OCT to image structures deep in the eye is sometimes challenging because of the focusing required and so on and so forth. Now here, I think we can all see clinically that there's a PC rupture there. And here, if you look carefully, there's one edge of the rupture at the top and another edge where that scroll edge is at the bottom that shows the other end of the capsulorhexis. I think most of the times when we see a PCR happening in front of us, we know it's a PCR. But I think this is again a useful tool to show our residents as well that this is what's actually happening in the eye. So this is my second case after the deliberate posterior capsule tear that I made. And here again, you can see that little defect, that's the edge of the PCR, I mean. So here, so the sign I'm going to call it really is the OCT scroll sign of a PCR, which I think is a useful thing to have if you're not sure that what you have is just a wrinkle or a stress line in the posterior capsule, or is it really a PCR? So let me show you this third case, which is actually very interesting. This was a 53-year-old man we saw recently. He and his friend had been rock climbing, and they disturbed 3 bees' nests. And they were attacked by this swarm of bees. And in fact, his companion died from the bee stings. He himself was stung all over the body and eyes. And actually, he had to go into ICU because of multi-organ failure. One eye, the right eye, was blinded because of the bites in the eye, stings in the eye. And the left eye was also stung. His cornea started melting, so they put an epithelial patch graft on it. He had endophthalmitis, and they did a vitrectomy on him. And of course, after that, he developed cataract and came to see Donald Tan for the cornea. And then Donald asked me to help him with the cataract. So this patient, you can see here, that's where the cornea was melted and epithelium was there. And excuse me, you can see that it's a dense white cataract here. And, I got a good capsulorhexis. And as I was doing the phaco, I noticed that the consistency of the cataract was nothing like a normal soft heart or neither here nor there nucleus that we're so familiar with. This cataract was sticky and gooey and stuck to the capsule, and it really was stuck to all the other structures around the lens capsule. And it was a challenge. I thought this would be a simple aspiration of the cataract since it was just a 50-year-old. So being patient, I eventually managed to clear most of the white cataract away. And at the end, I'm just doing my IA of the last bit of cataract. The view isn't great because this quadrant of the cornea is hazy from the cornea melt. And then I see that line there. Do you see that line distally there? Now, Donald's sitting with me because he's looking at the cornea, and then he said, I think that's just a wrinkle. I think it's a PCR. Donald says, no, I think it's a creased line in the posterior capsule. I said, well, let's turn on the OCT and see. If you look down here, you will see that's the scroll here on the bottom right image. So the use of the technology was useful, especially if your view of the posterior capsule is compromised. So I put in a 3-piece IOL, and this is thanks to David's teaching, of course. You know, many a times when you've got complex cases like that, putting a 3-piece lens with the haptics in the sulcus helps. And I captured the optic in the bag, and you can see from the OCT image that the anterior capsular lens is in the bag there. So that's the end of that particular case. So it was very useful in confirming the presence of the PC rupture and also the position of the optic in the capsular bag. So just to repeat again, this is the scroll sign of PCR seen on the IOCT. Now, how do you distinguish that from just a crease line? Now, here's a crease line, or at least I think it's a crease line, or is this a PCR that we often see after an IOL has gone in the eye? The difference is, if you see this fold or this scroll here, it's continuous. You can see the line going all the way across the back of the lens in a wavy nature. And the other things you see, I'm putting the cannula on the left, and when you press, those crease lines disappear. And you can see that those scrolls have been flattened out by the simple maneuver of just pushing down gently on the IOL, and confirms that this particular diagonal line was not a PC rent, but just a crease line from the IOL haptics. So just to end with again, this is the OCT scroll sign of PCR, and I think that the IOCT is a pretty useful surgical aid. It helps us confirm PCR in those cases where we're not absolutely sure, and it also helps us confirm that the optic has been captured, whether it's anteriorly or posteriorly in the position that we would like it to. Just a reminder, I'd like to invite everybody to join us in our virtual APA CRS meeting in July this year. And thank you very much for having me here again.
Thank you,
Fantastic, Ron. Namrata, you want to say something first?
I just want to say one thing, Ron. I've seen, I mean, all your IOCTs are in grayscale. So if you see the original one, it comes in green scale.
Yes.
So why do you, I mean, I just want to know why you would want to see
Great question.
on green scale.
Great question, Namrata. Well, you know, I do a lot of photography, and I often like black and white photography because it doesn't distract from the essence of the matter. You know, when you take a color photograph, say of you, I look at your clothes and your lipstick and the color, but I don't see your soul. When you do a black and white thing, you see the essence.
Okay. Otherwise, I think it is a very, very important sign which you have, you know, shown, and which I'm sure is very useful, especially in hazy corneas where you can't make out whether a rent is there or not, and also for captures, anterior capture and posterior capture both, which can be so beautifully. You also demonstrated in your cases.
Ron, I just wanted to ask you one question. What is it when you remove the viscoelastic from behind, both in the toric lens as well as in the multifocal lens?
What is the reason?
Yeah.
Well, you know, I did, in fact, using the IOCT as well, I looked at a lot of my cases, those in whom I took out the OVD and those in whom I didn't take out the OCT. And if you don't remove the OVD, there is still a layer of OVD that stays there for, I'm sure, it's several hours before it's removed. And if you're putting in a toric lens, I think the risk of rotation is higher. Sure, for the non-toric synergy, I didn't need to do that, but I'm just a creature of habit. I just go in every time and remove all the OVD. I like to image that my optic sits snugly on the posterior lens capsule.
Professor Tityal is here. He's also done a lot of work on intraopacity. Sir, are you there? Yes, sir.
I was listening to all the discussions.
He doesn't do so many PCRs, so probably, I don't know.
No, it was a wonderful insight to looking to posterior capsule. I think for a cataract surgeon, that's the most important layer to be safeguarded. And we do have some challenges also, especially the hazy cornea where things are not sometimes visible. And this sign is definitely going to at least enhance the, your thinking, and subsequently management may be simpler. Otherwise, OCT has given in cataract surgery, we thought initially it will not be useful in cataract surgery. We are using only for retina and corneal surgeries. In fact, it is very useful in cataract surgery, which we also tried from using OCT with the femtosecond devices, OCT, handheld OCTs before this. It does help you to understand the entire morphology and the dynamicity of each layer of cataract surgery, right from the anterior capsule, which Ron showed very nicely, then going to the nucleus, then the epicortex, cortex, addition, posterior capsule, IOL, everything. And during hydration of wound area, you can see how much the capsule moves beyond the lens normally remains static, but capsule can still be mobile. So people have titrated how much fluid you have to leave it at the end of surgery so that lens and capsule remain almost together. So various things have been shown very nicely with OCT. I think this has to be a part of not only for teaching what Ron was saying. I would say it should be a part of every surgeon so that you can see what actually you are doing on the table. And the first thing which I thought, it was useful was, it's like a phakic IOL. My first publication of phakic IOL, ICL. That was the first publication of phakic IOL to see how much is the bolt in the intraoperatively. And we could titrate that. And that was just, I think, game changer for, all intraop surgery as far as I am concerned.
Thank you, Dion. I think Sun Ping had a question.
She had a question.
Yeah, thanks, Ron. Very interesting talk. I just noticed that, if your rib is not directly across the center of the posterior capsule, but was like, off center, especially if it's a bit curved, like you showed in the first case where you had a very impressive scroll. I think that the scroll will only appear on one side, which is what I observed in your OCT, which just flashed by very quickly. So it's on the side where it's actually convex, because there's excess of that capsule, so it's able to scroll up. Whereas on the other side, it was just linear. So I've also managed to capture a PCR occurring during a posterior polar cataract surgery. And because posterior polars typically split right in the center where the polar cataract is, it was just linear and there was no scroll. So maybe if you are intending to publish it, you might want to make a comment that, it may not appear on both sides. It's usually on the side, especially you would see it only if it's not directly in the center, and that would be on the side where it's actually convex, because there's excess material.
Great observation. So maybe you can rupture a few more capsules and help me collect numbers.
No, this is because I'm working on a paper that's based on IOL that have been in the eye for years, and the patients are like chronic rubbers, and they split the posterior capsule. I'm sure you've seen a number of these cases in your clinic. And if you look at the split, you can see the posterior capsule scroll up, and you will notice that if it's the split's not right in the center, and often it's not, that part that's actually convex will actually scroll up. Whereas the other end is just a linear split that may be quite difficult to see and only visible when you put the light coaxial at the slit lamp.
Professor Chi, we have described the difference between the capsule opening in a posterior polar cataract and the iatrogenic damage to posterior capsule. What Ron was saying, the scroll is classically seen in iatrogenic damage, because you create a tear and flap in these cases. As you rightly said, in a posterior polar, it's just a split. And there you can't see the scroll, it is just a tear. So that's the difference. And most of the time it is very linear, elliptical, and you don't have those flaps.
Actually, I'd like to ask David for his opinion. David, you're an expert in PCRs, of course, but I'm grateful for your opinion.
No, I thought that was really great. What we really need is something that'll show us vitreous, and unfortunately, OCT really wouldn't do that. I mean, that would be really nice. But I think it's a technology. I'm sure it'll even get better and evolve. And thanks for that great set of presentations. It's nighttime here, and when I go to sleep tonight, though, I'm going to have nightmares about bees after your presentation.
I can see David is already looking sleepy. It's middle of the night. I think we'll quickly go on to the next speaker because right after John is David. I'll take the pleasure of inviting John Chang, who's a dear friend again from Hong Kong and does fantastic refractive and cataract surgery work and with premium IOLs, and he's been a past president of the ISRS. And John is going to speak to us on trifocal lenses and which one is best. And right after that is David before he falls off to sleep. Sorry, David.
Can you hear me and can you see my screen?
Yes, John.
Okay, perfect. So I'm going to move away a little bit from these wonderful talks and wonderful surgical techniques, and I'm going to talk a little bit about IOLs, implants. As you know, trifocals are now very popular, and I'm going to do some comparisons. I do receive lecture honorarium and sponsorship for an investigator-initiated study from Alcon for the Panoptics, and lecture honorarium from J&J. These are the lenses I use mostly: the Panoptics trifocal, the Adlisa trifocal, and the Fine Vision. These are the three I use the most. We did a comparison between mostly Fine Vision and the Alcon Panoptics, and we also put in the EDOF just to compare, just for comparison and to get a feel for the lenses. Now, basically, essentially, this is the Fine Vision, Physio, Panoptics, Symphony, and Adlisa right here. And the more rings you have, basically, the more halos you get. So this is the main thing. But the more rings you have, the stronger the near. I didn't compare the Adlisa with these because I use it mostly for high myopes, and I'll explain that why. But this is comparing the Physio, the Panoptics, and the Symphony, and obviously the Symphony is best for the distance vision, best corrected. This actually, the best corrected shows you the function, at the lens at its best. Okay, so now these are the function for the intermediate vision. Basically, if you can see J5 or 20/50 or better, you do not need glasses for computer. So none of these three lenses, patients with these implants need spectacle for their computer, but intermediate is stronger for the Part F compared to the Symphony and the Panoptics. For near, now again, a Part F at 30 centimeters, Panoptics is 40 centimeters, so their sweet spot for the lens, best corrected near, and the Panoptics actually works the best. And for J3, they're pretty much very similar. And obviously, Symphony is an EDOF, so near is weak. In terms of post-operative accuracy, the trifocal, as you know, the trifocals are not very forgiving. You really have to be quite accurate in your result. And you can see the Panoptics actually comes out the most accurate, about 90% within half a diopter and 94% within 3/4 of a diopter. None of the eyes lost any vision. The lenses are very good in terms of safety. The defocus curve is very useful for me. I do the lenses and I do defocus curve. It tells me what lens and when to use it. Now, this is the Symphony lens, and you can see the distance is very good. And this is the green is the Panoptics, and the blue is the Physio. Okay, and you can see at 40 centimeters, and overall near the Panoptics is the strongest, as I showed you just now on the table on the histogram. But particularly for 40 centimeters to 67 centimeters for office worker, this works well because it's strongest. Okay, and then for somebody, I'm talking about trifocals, comparing these two, of course. For somebody who likes to hold their things a little closer at near, then the Physio actually trifocal works better. Or somebody who does mahjong or play golf, who wants that intermediate and further better vision, then I recommend the Physio. Visual symptoms is really the only thing that I think stopping us all from putting trifocals in everybody or multifocals in everybody. And now the score 0 is no problems, 5 is very severe, okay, symptoms. So the trifocals are really pretty good. The 1.3, 1.4 for the Physio, and the Panoptics is the lower, and obviously the EDOF is the lowest. But if you look at the glare to me is very important for multifocal IOLs because that's your waxy vision. That's there all the time. There's morning, evening, all the time. And that's the reason, basically, why I have to explant the lenses. And actually, I've not explanted one for quite a long time. So even this is good, but particularly Panoptix has a low glare problem. And I like this, and I actually use this for the post-LASIK patients. I use a lot of the Panoptix because of the low glare. Halo really only happens at night when outdoors. So if the patient doesn't drive, and most people in Hong Kong don't drive, so halo is really not much of an issue in Hong Kong. But if they do drive, then you have to worry about the halos. Now, if you look at the overall satisfaction, 0 is very dissatisfied, 5 is most satisfied. Okay, very, very happy. So the numbers are 4.3, 4.47, very good. But Symphony is the highest, surprisingly, when we do monovision. Okay, and spectacle independence, though, still not as good as the fine vision and the Panoptix. I have been putting in some Ray 1s, and actually, unfortunately, I don't have enough because not enough patients to share results with you because of the COVID. So they're not too many of them coming back for follow-up for obvious reasons. But let's take a look at the literature, since I've already given you a feel for the Pot F and the Panoptix. Now, the Ray 1 for the distance, the post-op refraction, and the quality of vision score is similar amongst all 3 lenses. Okay, but what stands out particularly statistically significantly less good is actually the depth perception for the physio. The Ray 1 and the Panoptix are the same. And if you see the graph here, the blue is this is a defocus curve, and you can see that the Pot F physio is actually for the intermediate and distance to near to intermediate. The depth of perception is a little worse for the Pot F, and the same for the other ones. So study by Ferreira and Ribeiro, they compare Ray 1 and Pot F, similar, but just depth perception is better with Ray 1. And this is the same, another study comparing Panoptix, Adlisa trifocal, and the fine vision. And the Adlisa actually works very well. Okay, it's shown here. And this actually, Panoptix is strongest for the intermediate. And if you look at the defocus curve again, at 100% contrast, that is in bright daylight, the intermediate is best for the Panoptix, and the other 2 are pretty much the same. In dim light, Panoptix again better for intermediate work, but that's obvious because the intermediate ad is the strongest amongst the Ray 1, which is 175, at least a 1.66. So this is the strongest for the intermediate. This is a big study, 10,000 eyes, comparing all the parameters, distance, intermediate vision, and but these are statistically significantly better with the Adlisa, but not clinically significant because the difference is only 0.1 logMAR. And spectral independence, the micro F seems better than the Adlisa. But if you look at, this is interesting because the Adlisa seems to have the most PCO when comparing a micro F and the 839 Adlisa, and comparing with the Panoptix, Panoptix 3.3 and the Adlisa 17.2. So the Adlisa works well, but it has a higher PCO rate, and also in terms of, because it's got the most rings, it has the most halos phenomena compared to Panoptix and the physio. Other interesting technology, Ron already mentioned he used the Synergy. That we're getting very nice reports with that. We're just about to start, but I don't have enough in numbers to really present any good results to you. And the Ray 1 I have used also works very well. This is interesting as a dual optic concept where you put the monofocal toric in the bag, and then you put the sulcal flex trifocal Ray 1 in the sulcus. And the interesting concept is you can actually exchange the lens anytime quite easily. And also in the future, even 20 years down the road, when there's better technology on the sulcus lens, you just take it out and you put another lens. So that's quite interesting. So in conclusion, the Adlisa I use a lot for the high myopes because it goes down to -10 power, and then the cylinder goes up to +12. but it does have a slight higher PCO rate compared to the other lenses. The Panoptix has strong intermediate and low glare. It will work well in dim light, and I use this for the post-LASIK refractive surgery patient. The dual optics work well. The Ray 1 works well, and the dual optic concept is very interesting. The Physio has strong near and intermediate, but depth of field is a little weaker than the other two lenses. Thank you.
Thanks, John, for that brilliant talk. I mean, you covered all the trifocal lenses and right up till the synergy, which we recently had access to. So that was really an illuminating talk, and really enjoyed every bit of that. And I'm sure many of the surgeons here will relate to that. And, I think we'll go on to David's talk because he has to go to bed. And so David, Namrata, should I invite David for the next talk?
Sure, please do.
Okay, so it's really a pleasure to have David Chang with us today and late into the night. And he's been an amazing teacher. I've had the privilege of visiting him at his hospital and observe him operate, a flurry of toric IOLs. And he's an amazing surgeon, past president of the ASCRS, and so many more things that I don't need to tell that. Everybody knows him. And he's talking on a very interesting on how to prevent IOL rotation, and I've heard him speak very nicely on some of the toric lenses, how to prevent rotation. So let's hear David give his bit and enjoy that.
All right. Well, thank you very much for the invitation, and greetings from California. So this is toric IOL misalignment. These are my disclosures. They're not particularly relevant. Well, we all know we have so many different ways to mark the axis for toric IOLs. But this is a very important paper. It was a correspondence from Japan. And what they did is they looked at 72 consecutive monofocal tetanus torics. These were marked with ink at the slit lamp. But what was neat is they took digital photos for the alignment. They did it immediately after surgery, and then 1 hour later, as well as day 1, months 1, 3, and 12. And if you look at the total amount of mean misalignment at a year, it turns out that 28% of that wasn't due to rotation. It was actually surgical misalignment. And so you have to take the photo right after the operation to really prove that. Now, the most of the misalignment actually occurred to rotation of the lens, but it was just in the first hour. And so rotation after 1 hour, that was only 11% of the net mean error for the whole year. So a couple important things, but one of them is that when you see a lens that's not on axis, unless you know for sure that it was surgically misaligned, you don't really know if that was the lens rotating or you just didn't align it properly at surgery. And then when it does rotate postoperatively, it's almost always within the first hour when the patient starts walking. So I think this is a big plug then for image-guided digital image-guided alignment. We have the Varion system. We use the Zeiss Callisto, have for a number of years. And just to show you what that is, it's basically taking a black and white image of the limbal blood vessels with the IOL master. So we already get this automatically with biometry. We bring that to the operating room, input it into this computer, which then matches that image with the live image from the microscope. It's the limbal vessels temporally and nasally. And then we get the axis. So you see the 180 axis here, and then whatever axis I input, in this case 90, for the toricity. So it's very fast to register it. This is just the circulator who presses the buttons, and this is registering those two images. And then here we'll see the 180 degree. This happens to be the reticle from my aura. And then I am aligning the microscope right over the 180 degree axis. So that shows how fast it happens. It's very, very accurate. And then you know exactly, in this case, with 15 degrees, you get very precise alignment. So once the lens is in, I turn this off for the surgery, then I turn it on for the lens alignment, and you can line up the dots within this 2-lane highway of lines here. And you literally can tell when you're off by 2 degrees when you're doing this. So you know exactly where the lens was at the end of surgery. All right. So and notice I keep the eye soft. This is just showing when I started, I would make some ink marks my traditional way, sitting the patient up. And it was not uncommon for me to be 5 degrees off just with those ink marks. We know that for some patients it's challenging, for them to hold their eyes still. This is the best study. It's a meta-analysis of 5 different studies comparing manual, ink marks with digital image-guided alignment. And the image-guided did better in terms of alignment, less post-op astigmatism, and a smaller difference vector. This is a meta-analysis done from China. So what about the pearls for avoiding rotation? Just as we talked about with Ron's, I do use a non-dispersive viscoelastic and remove the viscoelastic from behind the lens. I don't want the lens to be slippery. I want some contact with the posterior capsule. We mentioned the Callisto digital alignment. Often we have to place the lens a little bit in the nasal part of the bag to align the center of the optic with the visual axis. And I actually think pushing the lens a little bit toward the side gets a little more contact on that nasal side with the haptic, but then leave the eye soft at the end. It will inflate very quickly. I basically don't want to overinflate the bag and the eye, and I kind of minimize the activity for that first few hours based on that study from Japan. Now, using this technique, my partner and I published a very large series of 1273 consecutive eyes from our practice, and just using the same technique and equipment. And half of them were monofocal Acrosoft and half monofocal Tecnis. This was really the first study in the literature where 100% of the eyes were actually aligned using digital alignment in the OR. And our distribution was pretty even in terms of the high and the low power toric lenses from each category. And what we found was that the Acrosoft had better rotational stability. Whether you look at 5, 10, or 15 degrees, it was highly statistically significant that the Acrosoft remained better aligned. If you look at more than 10 degrees rotation, remember, when you're 10 degrees off, you've lost a third of your toric IOL correcting power. The Tecnis toric was 3 times more likely to be 10 degrees off or more. And that resulted, not surprisingly, in double the frequency of repositioning those lenses back in the operating room. After publishing that, we then continued our study to include the onset in the United States of the first toric EDOF and the first toric multifocal. And so this was reported in 2019, and our publication has been accepted. It's online for general cataract refractive surgery and will be published soon. So now we're using the same platform, but for presbyopia correcting lenses. And in parentheses are the monofocal results. And so no surprise, the same platform has the same stability, whether it's a presbyopia correcting optic or a monofocal. But now when we look at that 10 degrees or a rotation or more, the Symphony toric, we had a 7% rotation rate back in the OR. And with the Restore, we didn't have any. So this is important because, the PanOptix and the Vivity now are going to use that same platform. And we'll talk about the J&J series. In the faded colors, this was our numbers from the first monofocal lens study. So now you can see we've got much larger monofocal IOLs numbers. And the original Tecnis toric very clearly is 3 times the rotation rate as its Acrosoft monofocal. But then when you go down to the Symphony, 7%, it was double the rate of the monofocal, but the rates of misalignment were different. What this reflected was the fact that we were and had to be more aggressive about repositioning IOLs that were for a presbyopia correcting category, because as you know, then the misalignment is affecting all of your depth of focus curve, and it has a greater impact or negative impact. So to our knowledge, this is the first study to really show this difference between the need to be more aggressive with a presbyopia correcting toric misalignment than the monofocal counterpart. I also published with Dr. Haripriya from Aravind in the current month's issue of JCRS their data from Madurai, and this is at one institution, but multiple surgeons. And Oralab manufactures a hydrophilic one-piece, single-piece monofocal toric, And we compared the numbers retrospectively with the Acrosoft, kind of the gold standard. The hydrophilic is important because this is at a lower cost structure. And obviously, even though patients are paying extra, the price of the American manufactured lens is just simply beyond the means for many of their patients. So having a lower cost toric that the patient still pays extra for is very, very valuable. And what was nice here is if you look at the repositioning rate, it was not statistically different. So it had good rotational stability. The total actually of 125 patients who had it recommended, of them, 95 had repositioning, and all of them did well with no complications. And so here you have the different percentages. And in our series, we had 105 patients who had repositioning. And again, none of them had complications, and we'll show that in a moment. Our study, original one, led to J&J looking at ways to improve the stability of their monofocal toric platform. And what they've done is frosted the outer surface of the haptic. This is now called the ZCU, and all of the lenses in the US now are the ZCU instead of the ZCT. And I've used this lens a lot, and I've actually not yet had to rotate one. So this one change, which kind of surprised me, I didn't think that that would be enough to do it, has dramatically improved the rotational stability by frosting the haptics. The current Symphony, even today in the United States, does not have this, but the new Symphony with IntelliLight, which we're expecting sometime later this year, will have the better haptic, and that's very important for a toric presbyopia correcting lens. I do want to spend some time finally on this topic of toric IOL repositioning and what do we do. So I'll just show a brief case quickly. I'm putting in a Symphony toric in this patient, and yet lo and behold, eight days later, we've got residual stigmatism. They're 20/40 uncorrected, and my axis is at 180 instead of 40. What do I do? Well, we do the refraction. We repeat the topography. No, it's the same. And then we go to something like this online calculator, astigmatismfix.com. And by inputting what the refraction is, it tells me what the best position of that lens should be. But very helpfully, it shows me the current refraction would change to what if I were to rotate the lens. And based on that, I'm going to go ahead and rotate it. Now, my technique is to not inflate the bag with viscoelastic. And if I do this within a month of implantation, even with the Acrosoft, with the terminal bulb, I can rotate this lens. I'm inflating with BSS while I'm doing this so the chamber doesn't shallow, and I'm trying to just nudge it along. And my rationale is that I'm not really inflating the capsular bag or making the lens slippery. And using this technique, again, in our paper, we reported on more than 100 consecutive IOL rotations without viscoelastic, with no continued rotation or re-rotation, and no posterior capsule rupture. So if you can't, of course, you have to reinflate with viscoelastic, but it's something to try, particularly if you do it early. So in this patient with this result, what did I do? I actually did their second eye because the Astigmatism Fix program gave me confidence that they would improve. I did their second eye, and while I was there, I rotated the first eye. I used the CTR in the second eye, and we had an excellent final outcome. So this is something, by all means, if you're doing toric IOLs, you should be prepared to do it. We should offer it to patients and be prepared to be more aggressive with that when you have someone who's got premium lenses. Thank you very much.
Excellent.
Thanks, David, for that fantastic, masterclass again on, IOL rotation and toric IOLs. And I think we've learned so much. I think we'll have the discussion right after the next talk, which is again, we will have a few questions to ask you, David. So if you'll just hang on for one more talk. And we have Boris joining in, and he's been waiting there on the side for quite some time. Boris, again, a dear friend and chief of the Fyodorov Eye Institute from Moscow, and having a small vodka with him as well, and brilliant work that they are doing. He's an innovator. Boris is going to speak on a very interesting subject today. anterior vitreous detachment in cataract surgery, and I think it should be a really interesting talk as well. And after that, we'll have a few questions for all of you. Maurice,
Thank
please.
you very much, Gaurav. It's my pleasure to be here with you today, and it's have been many years of cooperation in between the All India Ophthalmology Society and Russian Ophthalmology Society, and I'm glad to continue that in this COVID era, and I hope we will continue later on as well in the offline format. So I will be talking about anterior vitreous detachment in cataract surgery, and I don't have any relevant disclosures related to that particular subject. So I was interested in the clinical findings that we may occasionally all see at the end of the or during the cataract procedure, when the particles are located somewhere behind the posterior capsule, floating there, and obviously showing that the fragments of the lens that are created during emulsification somehow goes from the anterior chamber behind the lens and accumulates there and stays there. So, and that is the phenomena that was really described a long time ago by Dick McCool, who wrote this nice letter to the editor back in 1993. And also he was citing his personal book on cataract surgery and phaco emulsification, dated 1999, where he described this infusion misdirection syndrome, and when the fluid accumulates behind the posterior capsule, and there is a posterior capsule bulging forward. As shown here, this is intraoperative OCT, and we have a chance to see these nice images today from the other surgeon. And here we see the posterior surface of the IOL, the posterior capsule, and Berger space, which is the space in between the posterior capsule and anterior hyaloid. So, and shown here, this is how we see it during cataract surgery. And in our clinical observation, we've seen different variations of how anterior hyaloid it looks like. And this is the capsule, and this is the anterior hyaloid, and we see that it is not very even, and there is a destruction of anterior hyaloid, which is usually common in patients with advanced cataract and periodic exfoliation syndromes. And occasionally we see this image of the split anterior hyaloid. This is posterior capsule bulging forward during irrigation aspiration, and this is the anterior hyaloid, which is split into two pieces. So here, how the bulging happens, irrigation fluid goes through the zonules and pushes the capsule into the direction of the anterior chamber. And this is how you can see here. And even by compressing on the posterior capsule, you see that this fluid is quite strong, and representing that the pressure behind the posterior capsule is slightly higher than the pressure in the anterior chamber, probably because of the outflow of the fluid through the main and side port incision. So this is also representing that the balance of pressures in between the anterior and posterior chamber is not perfect. So this is again what happens when the phaco handpiece is in place and the surgeon is pushing on the capsule, showing that the pressure is quite strong and lifting the capsule. This is again happen during not only phaco emulsification phase, but also during irrigation aspiration phase. And sometimes this bulging is quite prominent and significant, and we have to be aware of that in order to avoid aspirating that capsule. And again, you see here, this is a double image of the anterior hyaloid, which is split into two pieces, and that is the case. So here's the mechanism of the posterior capsule rupture in these cases when there is a irrigation aspiration utilizing bimanual handpieces, and it's shown here. The capsule is aspirated and obviously damaged. So this is the case when irrigation aspiration phase of that procedure, and usually it happens when you try to polish the capsule, like in that particular case, and the radial folds showing you nicely what happens during that phase of the procedure, and occasionally, depending on the instrumentation that you use with coaxial handpiece, it's more frequent than in bimanual handpieces. And we all know that at that particular moment, we need to keep the anterior chamber filled. And it was already discussed in the previous talk that this is the rolled edge and this is the straight edge of the posterior capsule rupture. And you see how hyaloid is bulging forward through that capsule. However, hyaloid face is intact, and we are being able to press it down with cohesive viscoelastic in order to convert this opening into the very nice posterior capsulorhexis. And in that case, IOL is implanted into the capsular bag without loss of the vitreous. And here we can see after inflation of the anterior chamber, the hyaloid is positioned quite far away from the capsule. We even cannot see the posterior capsule, but rather the hyaloid, which is located 1.5 to 2 millimeters backwards. So here's the images that we do have. This is the patient after radial keratotomy, which you can see by these scars. And we know that in these cases, the zonules are usually weaker. So IOL is in the bag, posterior capsule with some cortical remnants on the capsule, and anterior vitreous hyaloid, which is detached. And we see that there is an adhesion still in the mid-periphery of that posterior capsule, which holds the contact in between the posterior capsule and the anterior hyaloid, and we published that observation at GSRS quite recently. So first of all, we want to conclude that intraoperative infusion misdirection syndrome, when the condition when irrigation fluid accumulate behind the posterior capsule and in between the posterior capsule and the hyaloid membrane. And the major predisposing factors are loose zonules and lysis of Vigor's ligament, which is attaching the anterior hyaloid to posterior surface of the capsule. And there are several clinical signs to keep in mind. And first of all, bulging of posterior capsule at the final steps of nucleus removal and during irrigation aspiration, making it very susceptible to damage. And we do think that it's a very significant risk factor for PC rupture, not only for the younger surgeons, but also for experienced ones. And we thank you very much for your kind attention.
Thank you, Dr. Boris. I think, again, that was an excellent insight into what happens through the intraop OCT microscope. And these things you can only visualize through the IOCT. Now, what happens is when you're actually doing surgery through the operating microscope, which has intraoperative OCT, it is much later that you see these things on OCT. I mean, you've already done those steps and, then you want to figure out at that point in time, or later on when you're looking at your recordings and then see, what it is, because the picture that comes in the operating microscope where your surgical pieces and where you're actually seeing the picture of the OCT in that is very small. So, and every time you have to actually move out and see that this thing outside, view it from outside, because that's a more magnified view. And I think they've made the picture small in your operating microscope because they don't want it to be interfering with your main surgery. So what do you think, Ron, you have to say to that?
I agree with you entirely, Namrata. The image in the eyepieces is almost unusable.
Yeah.
I would say. I mean, unless you turn off the other lights around and enhance it. So I always take my eye off and look at the big screen behind. But which is where I think when you've got the 3D, the imaging, the digital viewing system, then that probably will take that problem away. But it's looking as if more and more of our presentations are now dependent on IOCT, isn't it? I mean, Boris, you wouldn't be able to make many of these kind of decisions or comments really without the help of the OCT showing you the detail that you showed. And I think it's very good. And I think ultimately we're still learning. This technology is so new. I think we're still learning how to use this for cataracts.
I agree. I think that there are many useful things, and we are just starting to discover it. I agree with what was being said, and when you're looking through the oculars, actually the picture of OCT is superimposed on your operating field picture, and that's make it unusable. Absolutely. But I think we will be looking forward to having 3D machines where the OCT image will be integrated, I think, in much more useful way. And I'm looking really forward to have these two technologies merge at some point to make it absolutely give us the absolutely new view and new look to the operating field.
But isn't it interesting how when Zeiss and Leica, who are the two companies with this, promoted this technology as really for corneal and retinal surgeons only? And if you look in the literature, there's nothing about cataract. And I think that they're missing out on a great opportunity as a learning, research, and surgical tool.
I think the next thing that they should incorporate is a corneal topographer also into the same operating microscope, so that you can see how your topography is changing during the surgery and at the end of the surgery. So that will be a complete operating microscope as far as the anterior segment surgeons are concerned.
No, but Namrata, one more fallacy is that, as was discussed earlier, the focusing range is very limited, in the sense that if you really want to come onto a particular image, you need to focus, and you need to have somebody who is manipulating the image up or down to get to where it is. Like Boris showed the hyaloid phase or the vitreous coming out, etc. So that needs an adequate, excellent focus at that particular time. It's not as fast as if you can focus your microscope or the depth at which you can actually the focus. I don't know the exact width for which you can retain the focus, but the focus is limited, and you need to be actually focused onto that area.
You're absolutely correct, Mahipal, but you don't actually need an assistant, but you can actually control the focusing yourself. But I have to say, what I don't like is that when you're focusing the OCT, it's not in sync with your optical focus.
Yes.
And that's a problem, which I think the Leica system is in sync, but the Zeiss one isn't. So there's a bit of learning how to optimize the technology, really.
Yeah, but it's better focused if you look at the TV monitor rather than you're looking at the... So that's why you possibly need somebody to be doing that.
And also to be mentioned that there are sometimes you have a parasite images that are reflections from the cornea. So, and I think that the development of that technology will be in the direction how to get rid of these images, because sometimes in the area of anterior chamber angle, so where you really want to see something and you see this image reflecting, and that's really disturbing. So we need to improve that technology further.
I think Dr. Tityal sir has a lot of experience on 3D. So how do you think this has been taken care of in 3D systems?
I think it is, as we discussed, definitely it is better because you have a larger screen which has both, all the images are together. You don't have to look for, images through the oculars, which Boris had nicely told us that it's difficult to really see what is happening with the IOCT. But with the large screen, that is 4K screen, and you can see both together very, very nicely. And things are, for surgeons, it has become much more effective now. The only thing which is lacking is rightly told, like the focus has to be managed by, your assistant. If you have to have a microscope focus for you, the OCT focus has to be done by somebody else for a different positions of imaging. And other thing lacking is they don't have an actual micrometer. So we can't really assess the depth, the thickness of a structure which you are measuring. the new high definition system, they do have 3 marks which are at 1 micron apart. With that, you have grossly you can measure, but actual measurement is difficult, like you have anti-segment OCT in your hand. So that would be next, and they have to segregate both the focus, because in JAIS system you can do focusing, but you can't shift the image, your microscope image. That's the difficult part. So some lacuna is there, but I am pretty sure that will be improved very, very fast.
I think we'll.
I have a question on David.
One question to David, actually on the toric, the new frosted Technis lens. The results that I have seen, they seem to be the rotation issue seems to have been resolved to a significant extent. Are you part of any of those studies, or you have looked at it that it is now similar to that of Acrisoft, the rotational issues?
Yes, we shared our data from the original study with J&J, and they looked at it, and I think that was part of their resolve to really go back and redo it. And I personally have done, I think, more than 300 monofocals with the Technis 2. I have not had to reposition a single one, so I think that's totally solved it. And I'm a little surprised actually at how, because there's so many other differences between it and the Acrisoft. And I think it takes away from the original sort of hypothesis that the sticky nature of the Acrisoft was key to its rotational stability, because that one little change does it. And I think that's very important now because they're coming out with iHance and Synergy. And it's just, we're waiting because the Symphony in the United States still has the old platform. But it's really, they looked at about 6 different factors and different combinations, and they found that that was the one thing. I'll just tell one quick story. How do you make the outer edge frosted? Well, the lens is tumble polished. And so what they did is they developed little socks that they put on the haptics, and then they tumble polish the lens, and they take the socks off, and then the outer edge of the haptic is all rough, and that's how they do it.
And that makes it sticky with the capsule, the bag.
Yep, it's just more friction. It's just more friction.
Yeah.
And you can tell when you're experienced, because it's harder to rotate it counterclockwise in the bag. In our study, our original study, we found that the Acrisofts, they tend to rotate clockwise mostly when they're at 6 and 12 for the axis, but with the Technis monofocal toric, the first version, whether you start with the rule, against the rule, or oblique, they always went counterclockwise. So there's definitely a design factor that leads to that.
And
David,
sorry. Apart from making a frosted edge, did they increase the overall diameter? Because I think it's quite logical to do. However, it looks like they're not. Yeah.
They did not. Yeah, they did not. There was a lot of things they couldn't change. And of course, they didn't want to change too many things because you have to go through an FDA approval process and so forth. And so they were able to, I really thought that the haptic was more rigid. The Acrisoft haptic is more floppy. But, I was wrong. It's really that one change did it. So overall, I think, we're seeing with Vivity and Panoptics, very stable. I think we're now going to see that with the J&J platform. And so I'm just happy that I think both platforms moving forward have terrific stability.
And one question I think John has left. Anyway, maybe Boris, David, or Ron, or Dr. Su can answer. How much of the monofocal practice has been taken over by the iHands kind of a lens in your practices? Do you feel that that's really added something to the this thing? Because the price differential, at least in India, between a monofocal and an iHands is very, very less. And we're doing the iHands without any counseling or anything being told to the patient, because we don't charge anything significantly more, and the patients are really very, very, very happy with it without the dysphotopia. So are you all converting a lot of your monofocal practice to iHands?
I've completely changed all my monofocal IOLs to iHands. Maypal for exactly that reason. They priced it very well, so I don't even tell the patients what I'm doing. I may choose a little bit minus 0.5 if it's a second eye, or a little bit more just to give them a little bit of enhanced micro monovision, and they think I'm wonderful if they get something for nothing.
Yeah.
Why not?
What about Dr. Manshu Mehta? What about you? How many of your premium IOLs, or how many of your extended depth of focus have converted to eye hands? Your monofocals have converted to eye hands. Sorry.
Monofocals, almost everybody would be for going for eye hands. You don't have to tell the patient. You are happy, the patient will be happy. The happiness is in that. Multifocals still have a great place. Symphony is a very forgiving lens. You know, they're looking at all those results which was being shown here. David, just question to you. You know, when we start implanting a toric lens, what's your parameter? You know, sometimes people take off on a wrong tangent. Instead of going to US, they go to Japan. You know, if I have my original axis not planned well, what machine do you realize? You know, I mean, which one do you rely on? Is it the Varion? Is it the topography machine? Is it what axis do you take it as a gold standard?
Well, we do everything. We do topography, we do auto Ks, and then we do the IOL master in our case. You know, the IOL master, of course, you have the one advantage, which is that you're using the Barrett formula, which for an oblique axis factors in the effect of posterior corneal astigmatism, which actually bends the axis a little bit more toward 180. And then on top of that, we're using Aura to enhance the axis. Because, you know, too often, you know, different measures give you different suggestions for the axis and so forth. But I would say if you could only choose one, I don't think you do. You're looking for agreement. And of course, the most challenging is the low power when it's oblique, because, you know, it's not a strong axis to be as consistent. I was just going to just add, you know, in the United States, Eyehance is considered a monofocal lens. And in the United States market, our government insurance, it requires we have to use, we can only charge extra for a label for extended depth of focus, which Eyehance does not have. But Alcon's Vivity does have that. And the Vivity in the United States is really taking off because it's an EDOF lens, but there's no night images. And even though, you know, I think that, John's presentation was very good, you know, PanOptics, it's not bad. Symphony, it's tolerable. But just having to discuss that with patients, to be able to tell the patient, well, this one doesn't add halos, that makes it very easy for them to say, well, there's really then no downside other than the added cost. And also, because there's no issue with halos, we can aim for -1 and do mini monovision, or make both eyes a little minus if the patient prefers reading, you know, and is willing to wear distance glasses. So it's really, these are niches, which is sort of the optical profile of a monofocal lens with a greater depth of focus. I think what we're all saying, there's no downside to it, and then it's just a matter of cost.
And Boris, how about you? How would you, 30% of our cataract patients have PVD post-op. We noticed that. How can I avoid that?
It's still a matter of research. I think it's a lot of things that we don't know how, because we cannot see this detachment preoperatively. It's not possible. We can only see it intraoperatively. And the question is whether we are inducing it by our infusion, by constant fluctuations of the anterior chamber, or it's already pre-existent and we just opening that finding during the surgery. So it's still not clear, maybe both, because my feeling is that in the brown and black cataracts, you always have it. So I think that's the kind of, advanced cataract, and with the degradation of the capsule and dystrophic process in the zonules that may be pre-existent. However, in younger patients, obviously, we do create it by our manipulation.
Yeah, no, because it's very disturbing post-operatively, a week or fortnight later, the patient suddenly comes with a floater, and which wasn't there specifically. There are quite a few myopes who have noticed a floater before, but it's extremely disturbing because they really blame you for that. David, how about you in your practice? What do you do to avoid a PVD?
Yeah, no, I don't think we have much of a way to do that. But the only way to really avoid the floaters is to lose vitreous and do a vitrectomy. But that's not that's not the best way. That's not the best way. So no, I don't think any of us have figured that out yet.
Yes.
Oh, I think we'll move on to the next talk, and the next talk is by Dr. Chi Soon Faik, and from Singapore, very well known to each and every one of us. And she's going to be talking about handling vitreous. Chi.
Hello, everyone. First of all, I'd like to thank Namrata and the AIOS for inviting me to speak. So these are my financial disclosures with no relevance to my talk. So it's important to visualize vitreous, and it's done by diluting, adding diluted triamcinolone to stain the vitreous. So this is the first case here. We see that there is actually vitreous in the anterior chamber at the time of presentation in the subluxated cataract. So we have to attend to any vitreous that's in the anterior chamber because we cannot phaco with it present. So this is introducing a trocar cannula through the pars plana 3.5 mm posterior to the limbus. And because this is a fibro-cataract, the capsule is first removed so that I can then anchor the lens to support the lens. And then with the AC maintainer in the anterior chamber, we do a 23 gauge pars plana vitrectomy to remove the vitreous from the anterior chamber. And then we add all the supports to the anterior capsule. And the next important step is to insert a capsule tension ring done just under the anterior capsule, a plane that's been dissected out by viscoelastic. And then we reposition the lens so that no more vitreous presents because that gap is then sealed. So at the end of it, we have a nice stable lens that's been anchored to the sclera. So let's have a look at the next case now. So in this patient, you can see the lens is dipping into the vitreous, and vitreous is all over the anterior chamber. So again, we approach from the pars plana to do an anterior vitrectomy, and we really need to thank Abe for introducing this technique to us and popularizing it. So again, dissociated vitrectomy, infusion from the anterior chamber, from an AC maintainer, and then doing vitrectomy to clear all the vitreous that's in front of the lens. It's very important because we're going to go down to get this lens up into the anterior chamber to anatomical position. You can see only posterior zonules are present that support the lens as I spear with a 27 gauge needle. And once I fixated this lens and taken out the cataract, we then go back to the anterior chamber with diluted triamcinolone acetonide to make sure that there is no vitreous left when we leave the eye. And at the end, after we've stabilized the anterior chamber, we then remove the trocar cannula, which is very useful to leave right to the very end of surgery. So in this next case is a posterior polar cataract that has the posterior capsule is given away. And again, we have to do vitrectomy in here because I have a very good view, no lens fragments left. I'm doing it through a limbal approach. And this is a snug approach and is separate from the main incision so that the fluidics are stable in the anterior chamber. And we're removing vitreous that is already highlighted by triamcinolone acetonide. And following that, we can then begin to remove residual cortex, or in this case, epinucleus. And sometimes it can be a little difficult to remove with a retractor that has been switched to the IA cut mode. But you can do this by switching to just irrigation aspiration. And this is possible because there's no vitreous in the anterior chamber. You cannot aspirate cortex if there is vitreous in the anterior chamber. So after we remove all the cortex, and you can see even coming from the other side, we are doing through a snug incision so that vitreous does not lead forward into the anterior chamber. We have a good outcome here. So this other patient was done by my fellow, and suddenly the anterior capsule ripped, and you can see, and the nucleus is just behind, it's being nudged forward by a cotton bud, right? So there's no vitreous in the anterior chamber. And then we go into the pars plana approach again for vitrectomy. In this case, it happened just very recently. We'd run out of triamcinolone because of the COVID situation, and I'm just supporting the nucleus with my second instrument as I do the pars plana vitrectomy so that this does not drop backwards as we clear the vitreous. And then we are using the assistance of the posterior vitractor to levitate that nucleus forwards once we have cleared the vitreous in that space, and then stabilize the fragments with dispersive viscoelastic inject a 3-piece IOL into the anterior chamber supported by the iris, and then we go back with phacoemulsification. Because the incision has not really been enlarged significantly, we can still proceed with normal parameters to remove the remnant hard nucleus without vitreous coming in the way and without fear of snagging vitreous and tearing retina. At the end of that, we go behind the lens again to make sure we have no vitreous in that space, and then we can clear cortex from the capsular bag behind the IOL using IA cut mode. And in this case, because of the anterior capsule rib, I did an iris fixation. This is another patient with Morganian cataract, and after opening up the anterior capsule, you see it was fibrotic. I had to actually make a cut to complete it. The nucleus actually just began to sink, and I really had done nothing. I had not even done hydrodissection. So we bring this forward, and again, I'm going to approach this from a past planar approach because there's already vitreous in the anterior chamber. So after injecting triamcinolone into the anterior chamber to stain the vitreous, we then cut posteriorly, and it's really challenging to see the cutter through this dense cataract, but you can just make it out, right? So it's important that we go anteriorly and not into the central cavity where we do the cutting. And again, once there's no vitreous in the anterior chamber, we then insert the 3-piece IOL into the anterior chamber supported on the iris, and then tackle this dense nucleus. Fortunately, this was a really high myope with axial length of 30, had a deep anterior chamber, and I could actually phaco a little away from the endothelium. So after this, we then again check for vitreous in front of the IOL, behind the IOL, remove whatever cortical remnants there are, and then manipulate this into the sulcus space, and then we had a good outcome for this patient. So this is when we see vitreous presenting years after surgery, and this is a pseudophakic IOL, EDOF lens, and you can see the vitreous collapsing into the anterior chamber as it is highlighted by triamcinolone again. And we're going to have to do a posterior approach definitely for this case to cut the vitreous, because if you did it from the anterior segment, you would never be able to completely remove it. So you can see as we're doing the cutting, we're pulling the vitreous posteriorly. The infusion comes from the anterior chamber, again with the AC maintainer, the 23 gauge Lewin-Key cannula, which I used there. And once we have removed it from the posterior segment, we then look at the remnant strands of vitreous that are there that are trapped by the capsule. And then we just remove the rest and go back one more time to ensure there are no remnant tufts there. And I then secure this with a capsular tension segment and center the IOL. So you've seen various cases, how we handled this, vitreous at different stages of presentation. So settings for vitrectomy include a low bottle height, a vacuum that is not too high, high cut rate, use a 23 or 25 gauge posterior vitreous cutter, usually about 1,000 to 4,000 cuts per minute, vacuum 2 to 300 mm Hg, and bottle height of 70 mm or about IOP of 30 mm Hg. I generally use about 2,000 to 3,000 cuts per minute. So in conclusion, it's important to stain vitreous and to visualize the vitreous, usually about a third to half diluted triamcinolone. We want to deal with vitreous as it presents in the anterior chamber. Never wipe or sweep the vitreous, it causes retinal retraction. Use bimanual or dissociated vitrectomy, and infusion should always be in the anterior plane. It's important to inform your patient after surgery, the complication, and also important to check the retina for retinal tears. Thank you very much for your attention.
Thank you, Chi. I think that was an amazing presentation, and sometimes I wonder how far can you go, inside the anterior and mid vitreous and maybe the posterior vitreous to get the lens into the anterior chamber and get it out.
Only she can do it.
Only she can do it. Those cases were just amazing. And
because you don't have your nucleus.
No, every time it was getting deeper and deeper and deeper. But superb collection of cases and very nice pearls, Chi.
I'm speechless watching that surgery. Congratulations.
Thank you.
Thank you, Chi. Now we move on to our next talk, and the next talk is going to be given by Dr. G.S. Dhami, and he's going to be talking about phacoemulsification in hazy cornea, light at the end of the tunnel.
Thank you, Dr. Amartya. At the onset, I thank AOS, Dr. Namrata, Dr. Mahipal, Dr. Gaurav for giving me a chance to be here with you. See, after seeing so powerful presentations of intraoperative OCT and chase manipulations into the chamber, many a times you feel you really don't see anything on the cornea and you have to do a phacoemulsification, especially in centers like us where we do not have a cornea immediately available with us. We don't have a corneal surgeon immediately to help you. My thanks. This whole presentation is an inspiration from couple of few presentations of Dr. Namrata, please. Well, corneal opacification is a major cause of blindness in the developing and the developed world. Associated age-related cataracts contribute to the poor visual acuity. Suboptimal visualization of the lenticular morphology can render intraoperative difficulty. And these presentations present you many times on the table when you don't have a choice or you have not worked for them. Well, at the same moment, you got to take a decision for the surgery, whether we have to do a phacoemulsification alone or a combination of corneal transplantation plus cataract. Corneas are not available that fast. We don't have center like mentors, Dr. Amar Agarwal, who can do all the procedures at one stage. So we think what to do. Well, the deciding factors are evaluation of the grade and extent of the corneal opacity, the haze in the cornea, the expertise of the surgeon. He chooses whether he's going to do a small incision cataract surgery, an ECC or phaco, or a transplant plus cataract surgery. Availability of a donor cornea is a great problem. Visual requirement of the patient and the risk versus benefits takes us to deciding the surgery in hazy corneas. And of course, we do give patient a choice. Well, the grade of opacity, extent of opacity, anterior layers of the cornea, we do ALK and phaco, posterior layers of the cornea. When the corneal surgeon is in hand, DESEX and DMEC, all layers are involved, a triple procedure. Then, what is the location of the opacity? Whether it is paracentral, it is peripheral, phacoemulsification alone can be possible. When it has a central corneal opacity, it may need an additional surgery of ALK and phaco. Well, surgical techniques are surely dependent on the placement of the corneal opacity and the eye you are operating upon. It can be a temporal incision and it can be a superior incision depending upon what part of clarity of the cornea you are facing under the microscope. And this all lets for a fraction of a moment for the surgeon to decide. IL power calculation is a problem itself. Optical biometry is mostly impossible. Axial length can be measured with ultrasonic methods. Other keratometry can be used for IL approximations. IOL should be a monofocal. Intraoperative requirements, a microscope with a good retroillumination, a must. Staining with trypan blue, dispersive viscoelastic, nylon hooks if the pupil is not dilating, and an endo-illuminator chandeliers light. Well, if we take out to this case, it's an opacity through which you can work. The only careful step here is getting a good raxis and a complete raxis in one step. Retroillumination gives the whole aid, whether you are doing a raxis or you are doing a hydrolamination procedures or you are continuing to phaco. A slow phaco, slow motion phaco with less power, and if you can elevate the whole nucleus, it becomes easy to emulsify it under a good viscoelastic in the anterior chamber, supracapsular, and in the RS plane. These cataracts are always nearly soft and they come out very easily with phacoaspiration itself, leaving a good cornea behind for the patient's useful vision. Well, many a times you are faced with corneas like this. Patient is not willing for a transplant, but he needs his cataract to be removed for reasons causing a little of secondary glaucoma, a little of visual rehabilitation. These are difficult to approach, but not impossible. Trypan blue staining, a good Raxis under a good viscoelastic. Of course, retroillumination is the sure and a good method to help. Visual clarity can be obtained by repeatedly putting viscoelastic on the cornea. It gives magnification, it gives a better view, a better transparency, of course not very good, but definitely better. And Rexes got to be completed in one go. That's one thing which you cannot miss. Again, these steps have to be carefully performed because the visualization is poor. You have to hydrate or hydrodeluminate the cataract, do a slow phacoemulsification, saving the corneal endothelium for a good residual vision by a good viscoelastic, preferably repeated installation of the viscoelastic, which is a must. And finally, you are able to achieve something which is useful for you, your confidence, and a good vision for the patient. Of course, no denial that you need a transplant here, you need a triple procedure here, but limitations are innovations, and we want to complete a procedure, and the patient can then quietly wait for a transplant or to be referred to a good surgeon. Now, this is a challenging case where nothing is viewable, but patient has come for a phacoemulsification or a cataract surgery. And we have no choice except to use See, this light gives you an excellent view of the cataract. The corneal opacity virtually fades away, and you can do a safe phacoemulsification. Again, a complete, large, and a good wing capsular access in one go is what is must, especially when you come under the corneal opacity. Hydrodelumination is a very important procedure. Though the phacoemulsification is difficult, but when done patiently is very easily possible, and then the patient can easily wait or for his further visual rehabilitation. The all steps of phacoemulsification have to be taken very carefully and very patiently. things are quite different than a routine surgery. You just can't get hold of the nucleus, but little patience will definitely allow you. And this is called as a forward chop, holding the nucleus and cutting it from the back. Removing the last piece is equally, well, here what we usually practice is do a one-hand phaco. That is, once you have these pieces, remove your chopper and these pieces will safely come into the phaco handpiece. The whole procedure has to be patiently done and at a low parameters. Conclusion, well, these are the choices when you don't have everything at your center, but you need to choose the patient, explain to the patient, explain visual prognosis. A good microscope with retroillumination is a must. Surgical technique should be comfortable to the surgeon and patiently done. Thank you.
Thank you so much, Dr. Dhami sir, for that excellent presentation and very challenging case, especially the last one with retroillumination done. We'll have one comment from Dr. Mahipal Sachdev and Dr.
Thank
David.
you very much. I think the Chandler's illumination is a fantastic technique which was described several years ago. And the important thing in this is that the microscope light needs to be off and you have the Chandler. It's a self-retaining endo illuminator, so you really don't need an assistant to hold it. The one thing which Dr. Dhami I'll wish to emphasize is that using a trypan blue as you used is something which is very important because it adds to the visualization that you're getting. And the second thing is the depth perception that you get is really, really fantastic when you're doing a nuclear chopping. It's like as if you're looking at a 3D image. That's what you get because of light coming from behind. So the depth perception is excellent. And I think in corneal opacities, it gives you great outcomes. Where a graft is not, so the cornea is not available. International patients are not being allowed to be grafted in India as per the law, things like that. So we're getting a lot of these blast injuries from Afghanistan and Iran, Iraq. So they have these powders, etc., in the cornea. So Chandler illumination, I would say, is a good technique. And if you have a vitreoretinal person along with you, you can easily do that. And it's not something that we don't have. All of us have the Chandler's endo illuminator that is there. So apart from the other things, I think more and more people should go on to the Chandler's endo illuminator technique in corneal opacities, which is giving you good visualization.
Yeah, thank you. Thank you.
David, you wanted to say something? No? Okay.
Ronald, have you had the chance to do IOCT guided phacoemulsification, for cases of cataract with corneal? And do you think it kind of helps intraoperative?
Cataract with what? Cataract with what?
Intraoperative OCT, phaco
with corneal opacity. With corneal pathology. Not really. I wouldn't imagine it would image it very well, Namrata. I find that, the dense cataracts, often I can't even see the posterior capsule and the deeper layers. So I don't think it would be very helpful if you have severe corneal opacity.
So next we come
Yeah,
to
Dr. Chi wants to say
Dr.
something.
She wants.
Yeah, sorry, I just want to make a comment. I noticed that towards the end of the case, the pupil was coming down, and so the illumination got less and less. So I think in these cases, it's important to have a pupil that's, retains in size so that you continually have this illumination that helps you with the surgery. Thank you.
Thank you.
I think in these cases, even if you put nylon hooks, it kind of helps
Yeah,
because
there's
it
no problem.
expands the area of visualization. So with this, we come to the next talk to be given by Dr. Arup Chakravarti from Chakravarti Eye Center. He's also the editor proceeding for All India Ophthalmological Society, and he's going to be giving a very important talk on a very important topic, phaco in compromised rexes.
Good afternoon, all. And at the outset, I'd like to thank AIOS for, for this amazing array of international speakers. I am going to talk to you on phaco in compromised rexes. Nothing financial here. One of the basic prerequisites of a safe phaco is an intact rexis. And most of the time, the rexis is indeed intact. However, from 0.79 to 5.55% of the cases, there may be a rexis compromise. And what do we do if we have a rexis runaway? In fact, there was a publication from Moorfields at the American Journal in 2015, where the incidence of compromised rexis was 1.5%. And in the same series, PC rent was noticed in 1.65% of the cases. So when we are confronted with a compromised rexis scenario, how do we proceed? The decisions that need to be taken are, do we continue with phacoemulsification or convert to a non-phaco, a safer non-phaco technique like SICS or extracapsular cataract extraction? Now, if you decide to go ahead with phacoemulsification, do you use the same technique that you have been using endocapsular, or do you perform phacoemulsification at a different level altogether? And finally, if the phaco goes on smoothly, the intraocular lens, would you be opting for a 3-piece hydrophobic acrylic lens or a single-piece lens? And what if it was a patient who desired a toric lens or a multifocal lens? So these are the issues which I'm going to discuss in my presentation. Timing of the tear is very important, and I'm going to talk to you about the primary rexis tear in manual phacoemulsification, where you get a tear during the rexis construction. I have also encountered the same problem as a secondary rexis tear in situations where the rexis was small and the visibility was an issue, and for some reason or the other, the rexis margin got damaged, got injured either by the chopper or by maybe the phaco handpiece or by the phaco tip. We also need to look into the risk factors which predispose to these complications so that we can give a better counseling to the patient and can have a better surgical armamentarium plan for the complex situation. I have last 27 years of my phaco career, more than 10-15 cases, and I'm going to show you one video here. This was an intumescent cataract with a very high intralenticular pressure. Anterior capsule was stained with trypan blue dye, and I'm using a soft shell technique. Plan is to make a 2-stage rexis, and it goes on pretty well to start with. But at one point, I realized that there is an edge which tends to run to the periphery. So here you got to be careful. So I again inject a cohesive OVD peripheral to where the rexis has a tendency to run off to. Since I didn't have much purchase on the rexis with the cystitome, I use a nutrator forceps. But then again, there is little control over how the rexis progresses. And though I injected Hilon GV on the peripheral aspect, still there is a rexis runaway that happened. Now, my presentation today is not on what went wrong with the rexis and what could have been done, but rather how do we go ahead henceforth? How do you manage the subsequent steps of cataract surgery? So I would like to have about a 5 to 5.5 millimeter opening of the central anterior capsule. So I use my microrexis scissors and forceps from the main incision and from the side incision, from the side ports, to give me a very good access to the underlying nucleus, which is pretty much hard. There are some surgeons who believe in giving an opposite relaxing cut to the rexis margin. I haven't done it, but I think I reckon this is one of the options. Hydro steps should never be performed. I never perform hydro dissection in intumescent cataracts. because there are no adhesions and there is no need to perform a cortical cleaving hydrodissection. In this situation, if you try to do that, there is always a possibility of the rhexis stair extending to the periphery. Now, we have had publication, Dr. Rohit Om Prakash, about capsular flap motility sign. So in this case, both the edges of the rhexis stair are everted, which tells me that most probably the rhexis stair hasn't become a wraparound tear. So I go ahead with phacoemulsification, make a deep beat or trench with a very high phaco power because I don't want the nucleus to be moving around. And then I start chopping a vertical chopping using just the Sinskey hook. While chopping the nucleus, just ensure that the nucleus is elevated little anteriorly so that the chopping maneuvers do not have any extra force transmitted to the area where the rhexis was torn. At several points in the surgery, the anterior chamber was topped up with viscoat, a dispersive OVD, because you need to protect the corneal endothelium. I'm performing phaco at a little anterior plane, so this is very important for us to be mindful of the cornea and protect the corneal endothelium, as well as maintain the anterior chamber depth. And again, when you perform the chopping maneuver, it is always better to avoid the area where the rhexis tend to run to the periphery. And the nucleus rotation has to be done extremely gently. The basic game plan here is the bag is already compromised, and we don't want to create any further damage by inducing additional pressure within the capsular bag. So all the maneuvers go on in a very slow motion. Anterior chamber depth has to be maintained, and though I have edited out injection of the dispersive OVD, that was injected several times. So using this maneuver, the successful phacoemulsification was achieved. The nucleus, if you see, is not a very hard nucleus. It's sort of a brittle nucleus. Maybe that is the reason why I decided to go ahead with phacoemulsification in this case. Adequate cortex removal was performed. And then here, I decided to use a 3-piece hydrophobic IOL in the sulcus. So though I agree that a single-piece hydrophobic acrylic can also be implanted in the capsular bag, because the unfolding is very slow, but in this particular case, this was my decision. So here, the incision is enlarged to about 3 millimeters in size. We do not want the anterior chamber to become distorted, cornea to be distorted, and anterior chamber to become shallow. And just make sure that the leading haptic clears the area of the rhexis tear. So if you are not careful at this stage, the leading haptic will go through the area where the rhexis is torn. There will be additional stress to the posterior capsule, and there may be a runaround tear. So the leading haptic just scrapes the anterior capsule, goes safely under the iris. It is resting in the sulcus. Trailing haptic is also compressed, and it is not dialed in. It is compressed and it is kept in this particular location, as you see here. So the lens, intraocular lens, is oriented 90 degrees. That is at right angles to the area where rhexis compromise happened. And secondly, I also obtained an optic capture, the buttonhole the optic through the residual rhexis margin, though there's a discontinuity. I have done more than 10 such cases of posterior optic capture. The lens is beautifully locked in place. There is always a risk of asymmetric capsular fibrosis happening postoperatively and the lens getting decentered, but such a thing I have not encountered even after a long period of follow-up. Postoperatively, this patient has been followed up for a long period of time. You see the lens extremely well centered. There's hardly any PCO, and these are the rhexis, compromised rhexis flaps which are running to the periphery, and the patient has been doing extremely well. So friends, what I'd like to tell you is rhexis is paramount for safe phacoemulsification, but in spite of that, we do have rhexis tears happening, and then we need to take a call as to whether we continue with phacoemulsification. It depends upon a number of factors which are listed here. The surgeon experience, perhaps a senior surgeon with number of years behind him would be willing to continue with phacoemulsification compared to a neophyte. The type of cataract is also very important. Are we dealing with a bruniscent cataract with a thick posterior nuclear plate, whether the pupil is small? The location and timing of the tear out is also very important. Now, if I'm doing a case which is extremely hard, by almost a very dark brown or a black cataract, the endothelium is not very healthy, anterior chamber is shallow, the patient and the patient's bystanders are a little difficult, I would rather not continue with phacoemulsification, but convert to a manual SICS technique. So when a junior surgeon, a young surgeon who is not not familiar with manual SICS, he encounters a case like that, I think it is a good idea for him to ask for intervention from the senior surgeon in the neighborhood, in the operation theater, or if none is available, then one can put a suture and the patient can be referred out. A patient, good results finally will be appreciated by the patient, rather than a poor result because of your unfamiliarity with the subsequent steps of bailing out from phaco to a non-phaco technique. Phaco can still be performed, endocapsularly, or if the rhexis is really torn and you feel that capsular bag may not be a very safe place to continue with the manipulations required for phaco, you can elevate it to a more anterior plane. When, of course, it goes without saying that you have to use a copious amount of dispersive OVD to protect the corneal endothelium. Use of an appropriate intraocular lens. So a 3-piece hydrophobic lens in the sulcus with an optic capture definitely is desirable. A single-piece lens, which because it unfolds slowly, it also can be kept. Even if it is a toric lens, it can be kept. However, in multifocal cases, when I've had a rhexis tear, either I have abandoned using a multifocal lens in these cases, or I've used a 3-piece platform multifocal lens in this rhexis compromised situation. So friends, in conclusion, good phaco is possible in rhexis tear situations. Condition apply, and if you follow all the guidelines, I'm sure postoperative outcome will be extremely good from the patient as well as the surgeon's point of view. Thank you very much for your attention.
Thank you, Dr. Arup. I think it was an excellent demonstration of how to go about when the capsular rhexis goes escapes or runs away. Thank you very much for that talk. Anybody would want to give a comment before we move to the final talk by Dr. Mohan Rajan? Yes, please.
A wonderful talk, and it's something we don't talk enough about. And unfortunately, I have experience with this complication more than I'd like to admit. And excellent points. I would just like to add, I think that the riskiest thing is when we rotate the nucleus, because we have to push the nucleus against the capsular bag. That's sort of the most forceful maneuver we make. And so I really, really try not to rotate the nucleus. With the horizontal chop in particular, you can start chopping it up and then lift out a heminucleus and just bring it into the anterior chamber. But I find that if you can just avoid rotating the nucleus, you can get away with it not extending. And then the other thing is I'm continually amazed with our premium lenses that you can put a single piece acrylic with a toric or whatever, and even though the haptic is aiming toward that anterior capsular tear, it just opens up really slowly. And as long, again, as you don't forcefully rotate it, it doesn't extend it. So a lot of times you really can get away with even a toric lens where the haptic is having to go out into that area where the tear is.
So thank you, David, for that useful tip. Anybody else? So we come to the last speaker, in fact, the rocking star of Indian ophthalmology, who's going to give the most rocking talk, and his talk is on management of rock hard cataracts.
Can I share my screen, Namrata?
Yes.
You able to see my screen?
Yes, please.
Yeah. Let me thank AIOS for this wonderful opportunity, Dr. Maipal, Namrata, and the entire team for this wonderful initiative of International AIOS webinar. Hats off to people like Dr. David Chang, who's staying back so late in the night, sir. Thank you very much, sir. And also Boris, who's always with us for all the conferences as well. I'm going to talk to you about the rock hard cataracts, the top 10 tips. You can see this rock hard cataract, it's like a piece of granite inside the eye. Okay, and if you try to do the phaco, then you can end up in various problems in this rock hard cataracts. What are the problems you can end up? There's a challenge to the phaco surgeons, difficult to crack the nucleus because of leathery attachments, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and postoperative corneal decompensation, increased incidence of PCR and nucleus drop as well. Number one, what is the number one tip? Good preoperative assessment is very, very, very important. Do a specular microscopy, make sure the cornea is not sick, and grading of the nucleus is also very important. Pupillary dilatation is also a very, very critical component of the surgery, and the age of the patient is also important. As the patients go older, the zonules are likely to be weaker. combine the technology with the technique in super hard cataracts. Technology like what you have, it's available to everybody, Stellaris, Ocel, or Centurion, or whatever, or Ellipse. And technique is vertical chop using a sharp chopper. And you can have the various missions here, and even missions like Apaswami, the TurboWit, or the Robo is working very well. If you do the conventional divide and conquer, the stop and chop, it not only takes a longer time, but you end up in a burn like this, a corneal burn. You know the consequences of a corneal burn: irregular astigmatism and wound gaping, infection, even endophthalmitis as well. You can have a corneal edema like this, which can take a long time to clear. The corneal edema sometimes may not clear up at all, and the corneal edema can be associated with a high incidence of cystoid macular edema and something like a TAS in the anterior segment fibrin reaction. And the incidence of cystoid macular edema with the corneal edema like this is as high as about 25%. And you can see something like a fibrin reaction. Number two is, I do these patients under peribulbar or parabulbar anesthesia because I want to make the patient comfortable. I'm also comfortable because I'm expecting a little longer surgery for these patients. So this is again a very, very important thing. Don't do these patients under topical anesthesia unless you are really very experienced. Rexis always use trypan blue. Very, very important. Make a Rexis which is slightly larger, about 5.5 millimeter will be in the critical size as far as this thing is concerned, because I need that space to chop. Especially these cataracts are very, very big, 8 to 10 millimeter in dia, and very thick as well, 5 millimeter to 6 millimeter. And that is the reason why I need to go a little larger as far as the Rexis is concerned. Why trypan blue? Because I want to know exactly where my Rexis margin is while I'm chopping as well. Be careful in doing a hydrodissection. Don't be aggressive. You can have an underlying posterior polar component. Also, if you have a small Rexis and a huge cataract, you can end up in a problem like this. You can see is, as soon as my assistant puts the viscoelastic on the cornea, the nucleus disappears, probably because of hydro rupture, which has occurred in this case, which I didn't notice. Again, use a high phaco power for trenching. The normal misconception used to use less phaco power. If you use less phaco power, every time you trench, what happens is you push the nucleus. And every time you push the nucleus, there is a stress on the zonules, and zonules are already weak in these hard brown cataracts as well. Adequate tip exposure is very, very important. Again, because you want to go inside the nucleus as much as possible before you have produce a good vacuum seal. And I go bevel down. You can go bevel down or bevel sideways. This is a sharp chopper, which is a device made by Apaswami. I don't have any financial interest. It's got 1.5, 1.75, 2 millimeter. And you can see this is 1.5 millimeter, 1.75 millimeter, and a 2 millimeter, which is used for the brown cataracts. The 2 millimeter is also multi-purpose. You can stab somebody in the abdomen as well if you want to. Okay. And this is a tangential chop. You can see this is a tangential chop. This you can do in a little grade 2, grade 3 cataracts, but not cataract or rubra, cataract, what you call Niagara. But you can see use that in a high myopes when they have anterior chamber depth as well. This is an horizontal chop wherein you go under the Rexis and come from the equator. Again, you can see here in these brown cataracts, what happens is need a good cortical cushion. So horizontal chop may be a little tricky because there's no cortical cushion, there's nucleus and more nucleus, and the possibility of rupturing the zonules or damaging the zonules or even producing a PC tear as well. This is a quick chop express which are device. You can see here, I have using a Stellaris machine, whatever machine you are comfortable. I'm using a Rexis, which is about 5 to 5.5 millimeter in dia with a trypan blue. And then these are the parameters I use on a Stellaris PC machine, 60% phaco power, vacuum on a, seeing 450, 600 on a linear, duty cycle of about 40%, and you can see pulse rate of about 90 pulses per second. More importantly, you can see here I'm chopping. The first chop is very, very important. Direct the chop directly, vertically down, and making sure that you go all the way down and do the lateral separation. Being a sharp chopper, it opens up the posterior nuclear plate with great ease. You need to see the posterior capsule through and through when you're doing this chop. Then you attack each of these halves. Each of these halves and make it into multiple pieces. Make it into multiple pieces. So I'm doing the bevel down. I always do the bevel down. You can do bevel sideways because, or the bevel up, or whatever you're comfortable. Bevel down, I do it because I'm a little more comfortable because the vacuum seal occurs a little more faster with the bevel down. You can see here again, I'm chopping that cataract into smaller pieces, and I'm just going on the dual linear, which is available on the Stellaris machine, and going to the yaw position, and automatically the lenses start coming into the phaco handpiece as well. With another patient, you can see the cataract or rubra. Again, you can see I'm doing a trench, a small trench. The small trench just to make sure that I dip the phaco tip into the body of the nucleus. Don't go above, don't go below, go into the middle of the nucleus, that is the body of the nucleus. You can see how difficult it is to separate the posterior nuclear plate. The posterior nuclear plate is what is most leathery, and it's important that you go there and making sure that your left hand works much more than the right hand, making sure that you catch that piece on the right side, and then do the lateral separation and the vertical movement as well. This is a vertical chop wherein you chop right under direct visualization, right in front of the rexis margin, which makes very life easy. Then you make sure that the posterior nuclear plate is divided, and these patients is very difficult to do the hydrodelineation. There is no nucleus or epinucleus. There's only nucleus and there's no epinucleus. You can do something like a epinucleus or hydrodelineation in situ. It's just to make sure that the epinucleus protection is there while the nucleus is being removed. Just to make sure that you can see the cataract of Niagara, I'm just gradually increasing the grade of the cataract here. Cataract of Niagara, I make a little deeper trench in this particular case, gentle rotation, then chop. You can see here how I'm holding that piece. I'm trying to use the left hand more, doing the lateral separation. The chopper works like real magic, opening up the posterior nuclear plate without any problem at all. And these are the parameters you can use. Only thing is you need to use a high phaco parameters. You can use either Ozil, ellipse, or the hyperpulse, which is there on the Stellaris mission. Again, you can see the what you call the micropulse or the hyperpulse or the Ozil technology, which makes life, because the amount of phaco energy which is there, which is there in the anterior chamber, which is very less. It's a part of the cold phaco technology, which you use to prevent the chatter of the lens as well. So during the off time, there is a cooling of the tip and also the sucking of the nucleus into this thing. Again, you can see here the hyperpulse or micropulse makes it very easy for the cataract to be removed very nicely. This is another step which I would like to give as a take-home message. Introduce dispersive viscoelastic. I prefer viscode. I don't have financial interest into the anterior chamber now and then, because to prevent sometimes the pieces come and touch the corneal endothelium and can have a white cornea. So take time off and maybe now and then inject viscode into the anterior chamber to make sure that the corneal endothelium is well protected and you can have a clear cornea irrespective of the density of the cataract on day one. These are the various viscoelastic which is available. You can see these are the various corneas. You can see pristine wound, clear cornea on day one, despite the fact that the cataracts are very hard. If you have access to catalyst or femtophaco, for that matter, this makes life very easy, because the rexis is done, whatever size you want, the pre-cut is there, and you can see here, I'm just opening up the posterior nuclear plate. The very fact that the gas bubbles are coming up shows that the entire cut has gone through into the posterior nuclear plate as well, and this makes actually life easy. And the amount of phaco energy, as I told in the morning, also the amount of phaco energy is only 30 to 40% of my regular cataracts as well. Again, white cataracts, making the rexis is very difficult. I do the femto. So good preoperative assessment, peribulbar, parabulbar anesthesia, rexis, trypan blue, minimal hydrodissection, high phaco power for trenching, exposing the tip, vertical chopping or a karate chopping, and hyperpulse or the cold phaco technology for the removing the thing, and viscode through the side port now and then, go to the endothelium if you have access to femto. And this is a quick chop express which makes life easy, effective, and enjoyable, both for the patient as well as for the surgeon. Thank you very much, AIOS, for the wonderful opportunity again.
Thank you, Mohan. I think that was a very power-packed presentation. You just said it all. Anybody would want to comment? David?
Yes, sir.
Do you want to say anything on the intensity of the presentation?
Intensity of the presenter.
And the cataract.
Yeah, Dr. G, you want something? Yeah, go ahead.
Excellent talk, Mohan, as usual. I just wanted to know from the faculty of speakers here, for a very hard cataract, when we initiate chopping, do you think a vertical chop or a horizontal chop is more efficient. I know David loves horizontal. Mohan is showing us vertical.
Vertical, yes.
So perhaps we could hear about the pros and cons, of each, because as you mentioned, the first chop is the most important if you can get deep enough.
Yes.
Thanks.
So I think, David, you will have to answer that.
Yes.
Why do you think horizontal chop is better than vertical in a hard cataract?
I would definitely favor vertical for the dense lens, but I actually combine them. But the main thing is when you do vertical chop, you're starting the chop in a downward direction, and so it's easier to then when you separate the pieces, propagate it further. So you're just more likely to get through the posterior leathery plate. And I think what Dr. Mohan showed is getting a real deep purchase, and that's why you pre-sculpt a little pit or half of a groove. He showed that very nicely. And then the sharp chopper, it's less likely to displace, and it's going to more incise into the nucleus. You want to lift a little bit with the phaco tip as you depress to improve the the cleavage, and then that separating motion. And then eventually, when you get to smaller pieces, that's when I'll shift to horizontal chop. And maybe I would ask, have any of the faculty tried the MyLoop, which is the microfilament, and what's your experience been with that with the really dense cataracts?
Maipal has done it.
Yeah, so David, just to first talk about the vertical chop, I also prefer the vertical chop. The important thing in the vertical chop is that you need to depress the nucleus a little bit downward so that when you are starting to go into or bury into the nucleus, you are starting from above the half of the nucleus so that by the time you reach the maximum depth, you are somewhere at the center or this thing, because going in the periphery doesn't really help. And the second thing which I always teach people, or which I say, is that if obviously at times you don't get a complete separation, so rotate it 180 degrees complete and go in the same plane to kind of break it off rather than going at 90 degrees, because that leaves the interdigitations which are there. So getting two parts, the nucleus split into two parts is really good.
Another trick I would suggest, Maipal, is to go with the phaco probe vertically down. And not parallel to the capsular margin, which I forgot to tell, vertically down, as if you are going into the anterior vitreous. So that is the reason, if you go vertically down, then possibility of vacuum seal is better, and the opening of the posterior nuclear plate is better. And without opening the posterior nuclear plate, don't try to bring this nucleus up. If you try to bring this nucleus up, then you will have a white cornea the next day. So try to ensure that you see
deeper penetration. That is the most important thing, because you need to reach about 90% depth, 80-90% depth, and that is the key to the breaking. David, as regards MyLoop, I have done a couple of cases, and I think it works pretty well in hard cataracts. I even did it outside to see as to what it is, and short of there is something in India which is the betel nut, which is the supari, the hard supari, that it couldn't cut that. But it could cut an almond also, and it could cut kaju. I don't know what is kaju called in American, but all the different types of dry fruits, I tried it. The only thing which it couldn't cut was a betel nut. So that's really a hard one. But otherwise, rock hard cataracts also, it is, and it does not damage the posterior capsule. It looks a little difficult, but really you can do that, and within the space there is enough and more to have the MyLoop. It is the same material as you have in the nitolol material which is there, and which is very, very flexible. And a lot of studies have shown that it is very, very gentle on the capsule. So I think that's a great thing. The company is not really pushing it too hard, because for whatever reasons, maybe it replaces phaco, but it really reduces the amount of energy that you are using because you've already kind of pre-chopped all the nucleus into small little fragments.
I just had a point. I mean, building up on what Dr. Maipal has already mentioned, and Mohan and Dr. David, I would switch off the torsional. When I'm doing a very hard cataract, I will go to longitudinal rather than torsional, because that gives me a much better occlusion and much better grip. That's number one. And number two, I would not like to extend the vertical chop through and through because it requires a lot of lateral separation and trauma to the capsular bag. So I will do what Abhay Vasavada has described as a chop in situ. So I will see how far the chop line has gone, and then I'll take my instruments closer to that. Maybe I do a little bit of sculpting to go deeper to the posterior nuclear plate, and then make a fresh effort, but try to extend the same chop line from the distal area to the central area, from the periphery to the central area. So this is, I really don't want to divide the nucleus into two hemispheres at this stage itself. So once the chop line has come up to the center, then I rotate it, and then I get another chop line, get a chisel, get a small pie, and remove it. Then subsequently it becomes very easy, because then I know what the parameters are and what are the depth that is that's going to work out in the given case.
Dr. Tityal sir, would you like to describe your technique, because I know that you do it a little differently? Just unmute yourself, sir. Unmute you.
I've just heard all the top experts on phacosurgeries, and I combine all their techniques to my case, in fact. And the safest thing which I do for a super hard cataract is I do a deep sculpt in these cases, not a trench, bigger than a trench. Take out the center core of the hard core of nucleus away first. So it gives a space for a chop. It gives a space for your needle tip to go deeper also, for a hold. And the chop, I agree to Arup what he said. I don't use ozil torsion at that time. I use longitudinal in these cases. After I do a multiple chops, smaller pieces, then at that time you can activate the IP in this case. Yeah, and sculpt does help in all super hard cataracts.
So I think if there are no other comments, we come to the conclusion of this mega session on cataract and phacoemulsification.
I just wanted to make one point, Dr. Namrata. See,
Yeah.
Sir, you mentioned about IP being activated, but what I have noticed with the balance tape, IP really increases the chatter. If you switch it off, it slows down the whole process. So for suprahard cataracts, when I'm consuming the small fragments, I'd rather switch off the IP, and then things become much faster. I mean, it is of course an individual variation.
Thank you.
You make the cataract into smaller pieces, and then you switch on the IP.
Switch it off.
Yeah, switch it on. It works better.
With the mega tape, it is not.
No, he says off, you say on, so that's fine.
Off and on, off and on.
With the other tape, but with the balance tape, the bigger thing, it slows down the whole process.
In Trivandrum, it is off. In Chennai, it is on.
So thank you everybody for that great mega session, and we are going to be having individual clips for all the individual speakers. We'll mail them over to you. Of course, I know that you may not require them, but more importantly, we'll mail them to our delegates who really require them. And we hope to have you at another session on another virtual hybrid physical platform. So till then, thank you so much for sparing your time, and thank you so much for your contribution, not only to this webinar, but to the process of education in ophthalmology. Thank you very much.
Thank you.
Namrata, it was wonderful to have all our friends together today. Nice to see all of them, and it is such a refreshing, the situation. I hope it becomes better and meet them physically also. And wish them all good day, good evening, good morning to all of you.
Good night, David.
Good night, David. Good night. You now good morning after some time.
But you look very bright, sir, David, sir. Yeah.
Despite
I was falling asleep until your talk, and then it woke me up.
It woke you up.
Thanks, Boris. Thanks, Chief.
Thank you, Boris. Thank you, David.
Boris.
Bye-bye.
Thank you.
Thank
you.
Namrata.
Yeah. Thank you, Dr. Tityal sir, for always being there, and Dr. Mahipal sir for like a strong pillar behind all of us.
Thank you. Thank you.
Wonderful, wonderful work. Wonderful.
Superb. Namrata, fantastic.
Fantastic.
No, I thought AIOS is not happening, so let's do this on this weekend.
It's a brilliant idea. Brilliant idea.
AIOS on this weekend. So this weekend.
Absolutely. I think we should not forget, because every time, February is the month of AIOS for us.
Yeah.
Yeah.
Thank you. Thank you, Mohan.
Sir. Nice to see you.
Good day.